Hold on. There we go. Is that working yet? Okay. Well, welcome to everyone. All right. Okay, good afternoon, and I want to welcome everyone to the Assembly Health Committee informational hearing on improving outcomes through the patient-centered medical home. I want to thank all of the experts we have here joining us today to discuss the patient-centered medical home model and the implications for 40% of adult Californians living with chronic conditions. The reason we're doing this hearing is because as we're implementing reforms in the healthcare system under the ACA, but also just more broadly, we need to look at management of chronic illness, which is the source of much of our costs in our healthcare system. We did a hearing 2 weeks ago looking at risk pools and adverse selection because we know that one of the challenges was that we have in our healthcare system was related to basically managing the risk of patients who have chronic conditions as well as other illnesses. And some people have posed the question, well, then where are the opportunities to be able to better manage the costs and the risks in our healthcare system? And so this is, in many ways, the answer to that question. And so we are going to be looking at chronic conditions, models for addressing that, and particularly the patient-centered medical home as an approach to reduce costs while maintaining or even increasing quality. Now, I do want to thank, again, all of our speakers for taking time out of their busy schedules to travel here to Sacramento to discuss these important issues with us. And we really do have an excellent array of very knowledgeable speakers today. As you know, that the California Endowment has recently announced that they'll be funding a 10% state match for 2 Medi-Cal medical home pilot projects allowed by the Affordable Care Act, which I think is, again, another opportunity for us to build this model. We know that from a large and growing body of research that developing medical homes with patients and their families can play a key role in achieving what's been known as the triple aim of healthcare reform: better health, better care, and lower costs. So certainly what we want to do today is to identify what we as state policymakers need to know about the patient-centered medical home, to understand what patients will benefit most from this model and how, and taking a look at the barriers and incentives that exist around implementing this model and get a sense of how the Affordable Care Act recognizes the role of the patient-centered medical home in the delivery of health care. And I do want to thank my staff for the excellent work they did in the background paper. We also, in that background paper, attached an attachment that includes, I think, 4 pages of evaluation results on the patient-centered medical home, which I know, I understand that I think one of our speakers will be touching on as well in their presentation. So with that, I just want to welcome also my colleagues in the Assembly Health Committee, and see if anyone wanted to make any. I will ask very brief remarks, if any, if you wish. So, okay, all right. So let's call up the first panel here. We are the first panel. First of all, is Liz Helms, who's president and CEO of the California Chronic Care Condition, who's going to be addressing access to care in the chronically ill, and then Dr. Sophia Chang, director of the Better Chronic Disease Care Program at the California Healthcare Foundation, and also Xinyu Wu, the adjunct health systems engineer at RAND Corporation, and assistant professor of the Epstein Department of Industrial and Systems Engineer at the USC, who's going to be talking about the Wagner Chronic Care Model Evaluation. So we're going to be doing our this first panel on chronic disease, its impact, and how to improve care. So let's begin with Ms. Helms. Thank you and welcome.
Cents of every healthcare dollar is spent on chronic conditions. That's unacceptable when we know we can do better. When patients are not able to afford the tools and care necessary to manage their chronic conditions, they scale back or forego the care they need, which often leads to complications and suffering that could have been prevented and increases overall healthcare costs. We can do much better at building a healthy California while reducing healthcare costs, and we believe we're headed in the right direction with the work being done to implement the Affordable Care Act in 2014. Access covers an array of definitions, and while California is making positive strides to improve healthcare outcomes, social determinants of health and in the underserved communities contribute to all types of health disparities. However, we still see areas that need to be addressed if we truly want to accomplish an integrated team-based care approach. Covered California will improve access to coverage for all Californians, and especially those with pre-existing chronic conditions, but will it improve access to quality health care? There have been many names and models that share commonalities and best practices that have been viewed as patient-centered. In this capital, many battles have been fought on how to define it. When the patient is able to establish an ongoing relationship with a primary care provider, working as a member of the physician-led team, we'll be well on our way to shifting the paradigm from acute care to prevention and wellness. We applaud this legislature for bringing us all together to look at the best practices and achieve optimal outcomes. Managing complex chronic conditions can be difficult and vary based on the comorbidities each condition may present, including mental health, alcohol and drug addiction, as well as proper pain management and oral health. Many complex chronic diseases are genetic, but in many cases, their complications are preventable. The comorbidities of chronic conditions can lead to high blood pressure and diabetes, and obesity, as we're well aware, can for the first time in our history reduce the lifespan of our children. The Coalition believes a patient-centered medical home can work and lower costs when all members of the team are working at the top of their license and the patient is engaged and educated. But we're not there yet. We have underutilized our allied professionals and at their full scope of practice. And consider, for example, the use of the clinical pharmacist as a healthcare provider. Currently, pharmacists are not recognized in the Social Security Act or at the Center for Medicare and Medicaid Services, many allied healthcare professionals are recognized. Reform is essential for implementation of full team-based care. New regulations from CMS allow hospitals to expand the definition of medical staff. Medical staff has been broadened to include physician assistants, advanced practice registered nurses, and pharmacists to perform all functions within their scope of practice. But payment for services are not addressed, and true implications are not clear. How do we expect to improve outcomes when we don't include medication therapy management in an outpatient setting, especially for people with co-occurring complex chronic conditions? Compensation models reflect the range of care needed to be provided, and we need to really address that and look at how we can resolve that. And the health information exchanges for outpatient pharmacy are not well established and must be designed to bridge and improve the physician-pharmacist team, as well as integration into the full team home. Not only would that greatly be advantageous to Medi-Cal, but it would importantly improve the life of the consumer. We have improved outcomes and have demonstrated them through a model for success that we're doing in San Diego County through the Right Care Initiative demonstration, where both the clinical and the patient activation has been included. We have over 9 medical systems, and in all systems, public and private, working together, representing over 80% of the population in San Diego County. The University of Best Practices is the San Diego Curriculum, and the groups are now sharing their data, which is a huge move forward. And our patient activation and public awareness campaign, Be There San Diego, is also catalyzed by the Right Care Initiative, which engages the patient community to know their numbers and be there for life's special moments. The aim is to achieve both screening for risk factors and compliance with interventions, which is a full team approach. We've received national recognition through our unprecedented collaboration effort in San Diego, and statewide we've seen measurable improvements in the control of blood pressure, 7% for the state of California compared to 2% for the rest of the country. Huge marked improvements, and whenever we see that, we know we're saving lives. Jerry.
Thank you, Liz. I'm going to just take the last minute of our presentation to tie her remarks with Don Berwick's triple aim of care, health, and cost, which the chairman just referred to in his opening remarks. Liz's remarks can be summarized in a simple, single sentence: helping people live well with chronic diseases. Think of this sentence in the form of a question when you listen to the speakers that follow us. Will your ideas and recommendations help people live well with chronic diseases? And just consider that each time. We propose a list of follow-up questions in our written testimony that will answer this basic question, but I'm not going to specify them here because of the lack of time. But what you should try to accomplish is this objective. In this era of tight state budgets, you should embrace, not restrict, innovation and different approaches to implementing patient-centered medical homes and other initiatives to help people cope with chronic diseases. And why? Because we have the obligation to use our limited resources more efficiently, especially with more people coming on health insurance starting in 11 months, without compromising the quality of care. And I want to conclude by saying, let's get healthy, California.
Well, thank you. Thank you so very much. Next, we have Dr. Sophia Chang. We're going to be talking about an overview of chronic conditions and patient population. Welcome.
Thank you. Thank you for having me speak this afternoon. I was actually asked to speak a little bit more to kind of what the overall environment is, so we're going to zoom up a little bit in thinking about complex chronic conditions in California. As we've mentioned, we're dealing with an epidemic, so we're growing numbers, growing costs is the bottom line. And in particular, we're talking about 80% of our healthcare expenditures being spent on about 20% of the population. And so it's that 80-20 rule, and how do we think about using those dollars more effectively and spread them across more lives? We know, for example, that there is a high prevalence of chronic conditions. Here are the examples here in California, 27.8% of people with hypertension, 23.8% of people with obesity. If you notice, though, our overall averages are a little bit better than the rest of the United States. That's kind of the good news, right? We're a little bit younger, we're a little bit healthier. The bad news, though, is that the quality of the care that we're providing to these people with chronic conditions is still not there. If we focus on that bottom line, which some of you may or may not be able to see, we're seeing about 40% rates of improvement in some of our measures of chronic disease care, but we're seeing 21% of those measures actually getting worse over time. So part of the challenge here is to say, it's great, we have more people we need to take care of, we may be starting with a slightly healthier population, but are we doing a good enough job in providing them the care that they need? On top of that, we know that about 2 in 5 Californians have more than one chronic condition. And so these are just the medical conditions that I'm referring to and don't include the mental health conditions and substance use issues that were already mentioned as well. When you start thinking, though, about the multiplicity of conditions, then you start having an even higher risk of an individual not getting all the interventions that are appropriate to avoid secondary problems and, again, higher healthcare costs. This is just a map of California that shows that the prevalence and distribution of these complex chronic conditions really vary by geography. This is true across the country, but is also true clearly within our own state. So again, we talk about the fact that this is very expensive care, but I think part of the challenge is that who bears that cost of care really is spread out. 2/3 of it is really generally borne by the federal government, both in Medicare payments as well as their share of our Medi-Cal payments here in California. And then the other two portions which make up the rest of the third of these costs are the state, meaning us, Medi-Cal in particular, and private payers. These costs that we're spending on the disabled and chronically ill are pretty astounding. We're talking about an estimate in 2010 of about $635 billion. This is no chump change. And we also know that it's more than a linear relationship between the number of conditions and the costs. It's starting to actually take off. There's a multiplier effect. So the more conditions you have, the more and more costly you become. And so when you start to really look at the big picture, you can find, for example, that the top 5% of the population are actually generating almost 50% of the costs. So there's a huge opportunity in really zeroing in on high-cost patients and really lowering their expenditures. One of the big drivers then of these costs are, frankly, hospital care, right? So again, this is related to the number of chronic conditions, and readmission rates in particular are a real sign of a broken system. So when we talk about hospital readmissions, we're generally looking at a number of people who are readmitted within 30 days of discharge. So already, if you go back to these number of chronic conditions and hospitalizations, we look at which of those hospitalizations are frankly avoidable. If you have good ambulatory care, and one model is the patient-centered medical home, which you'll hear about, the bet is that you're going to avoid these hospitalizations. And then once you're in the hospital, you've got to have much better handoffs back onto the ambulatory side in order to avoid readmission and, again, avoid yet another avoidable cost. So this gives you a sense here in California that actually we're a little worse than the rest of the country in terms of our 30-day hospital readmission rate, so we have a huge opportunity to improve. And the other point I want to make here is that when you break this out by race ethnicity, here is a particular example of where disparities in care are probably making a huge difference. And the example in this slide demonstrates the high rates of readmission for congestive heart failure among African Americans as opposed, in this case, to Asians. So, in the interest of time, I'm going to just talk about a couple themes that you're going to hear about as you hear about specific models and interventions. What we have learned over time is in order to really maximize impact in addressing a better chronic disease care, number one, you really have to know what population you're talking about. You have to define them. You have to know who they are by name, by place, etc. And in that context, you're going to hear a lot about disease registries potentially in subsequent presentations, and that is one of the roles that those registries play, help you identify the population. The second is you really need to stratify both the population and the approach, meaning if you have someone with simple hypertension, the kind of care, the kind of team, the way you're going to engage them is going to look very different than if you're dealing with an elderly person who's demented, has diabetes, has congestive heart failure, as well as having chronic obstructive pulmonary disease, a very common complexity of conditions. And so when you are thinking about this, this is not a one-size-fits-all intervention, and that's something that I think that you all really need to keep in mind. Similarly, the patient-centered medical home is a delivery mechanism. It is not an intervention. And so when you're talking about how do you really think about improving the care, addressing the triple aim, you have to have clear, articulate goals and a really good mind's eye view of which patients are you really talking about, what are you trying to accomplish, and how are you going to accomplish it. And in order to do that, you really have to have good data systems to monitor. And so you have to know, again, not only who are these people, but what care are they getting and what are their outcomes. So I'm not going to go into this. You've heard about the triple aim. You're going to hear a lot about the patient-centered medical home. But I want to make one last note in terms of what some of the other primary cost drivers are that you may want to be looking at when you're thinking about what are the outcomes of the patient-centered medical home. So it's not only hospital and emergency department use, but it's also specialty care, the coordination of that care, because we know, for example, among many Medicare beneficiaries with multiple chronic diseases, they're seeing 12 physicians in the course of a year. Who's in charge? Who's the captain? And we're also concerned about unnecessary care. So when you have this many different people taking care of a patient, how many times are they duplicating an unnecessary test? How many times are they actually sometimes doing interventions that may not be appropriate given the complexity of their condition? So you're going to hear a lot about some of the short-term cost opportunities, which are listed here. The other thing I'm going to mention, because it's a pet of the California Healthcare Foundation, is that we also believe very much in good end-of-life care and thinking about palliative care and really honoring patients' wishes, which you may not hear that much more about in the rest of the afternoon. And that's it.
Well, thank you. That was a great summary in 10 minutes.
And I stuck to it.
And very good. Finally, to close out this panel, maybe I'll take a brief question. Mr. Amiano.
Okay, well, I could wait. That was excellent, and almost everything I was going to ask you hit on, so I congratulate you. I'm assuming this will be a team approach rather than a single. And then the contradictions in medication, a lot of us start taking medication and then from one doctor to the next, and then sometimes it'll have, so all that is and I'm glad you hit on the cultural competency part, because every culture deals with, yeah. Great, thank you.
Sure. Okay. All right. So the final speaker on this panel, and then we'll again open it up for questions, is Dr. Xinyu Wu, who's going to be talking about the Wagner chronic care model and she's deeply involved in the evaluation of this model as care for chronic disease. So, Dr. Wu.
Good afternoon. I'd like to thank Chairman Payne, Vice Chairman Lowe, and the committee members for inviting me to speak today. I'll be talking about what can we do. So I'll be explaining what the Wagner chronic care model is and how it is implemented in healthcare organizations through collaboratives and coaching efforts. I will also explain how an automated telephone call system based on the chronic care model can improve patient-provider communications and care management for high-risk, high-cost patients. In California, most safety net providers, including public hospitals, their extensive primary care clinic network, and nonprofit community health centers, face a grand challenge. As we just heard, the challenge is to use their constrained resources to provide high-quality care to an increasing number of uninsured and underinsured patients, the majority of whom have one or more chronic conditions. What we often found across the U.S. are rushed practitioners not following established practice guidelines, lack of care coordination, lack of active follow-up to ensure the best outcomes, and patients inadequately trained to manage their illnesses. Thus, Dr. Ed Wagner and his team in the McColl Institute in Seattle developed the chronic care model in the 1990s to improve quality of chronic illness care. Working with a small group of healthcare organizations, Dr. Ed Wagner demonstrated that the model was a feasible and useful guide to redesign clinical practice from an acute care-based approach to one that is organized for patients with chronic illnesses. In brief, the model recommends changes of healthcare practice in 6 areas. First, alter the delivery system design to include team-based care and proactive follow-up with patients, do care planning, management, coordination. Second, focus on patient self-management support, including patient education, empowerment, and support for their psychological and social needs. Third, establish provider decision support to include evidence-based care guidelines, protocols, and expert consultation to prepare primary care providers better take care of patients. Fourth, integrate critical clinical information such as diagnosis, treatments, lab results, and visit information in the patient registry to help providers make informed decisions and track patient progresses. Fifth, link patients with community resources such as transportation, finance assistance, housing to broaden support for patients. Also, provide health education and programs to improve the community environment that affects patient health. And 6, develop organizational policy and provide support to realize and sustain this chronic care approach. By making these changes, the model aims for providers to practice as a team and be better prepared to care for patients and manage patients' chronic conditions. These changes will also help patients take a more active role in managing their illnesses. Taken as a whole, patients' health outcomes will improve and the cost of care will decline. So, Rand and UC Berkeley, we did an evaluation called Improving Chronic Illness Care Evaluation. We assessed 54 healthcare organizations across the United States that participated in 3 chronic care improvement collaboratives, which were created to improve care for 1 or 4 common chronic conditions: diabetes, congestive heart failure, asthma, and depression. Each collaborative was attended by healthcare providers from 20 to 40 healthcare organizations. They met 4 times over a 1-year period to learn about the chronic care model and tested the change described by the model using the Plan, Do, Study, Act rapid change cycle method. That means they will plan an improvement idea, test it with a small number of patients, study how it works, and decide to continue change or stop the idea in a couple of months period. We found that, dependent on the implementation, the collaborative participants improved providers' effectiveness and motivation to care for chronic illnesses. It improved patient knowledge and self-care behaviors. However, public-funded organizations significantly implement fewer recommendations. They had worse understanding of the model, less time for quality improvement, and treating more complicated patients. A few important observations emerged from the collaborative experience. First, participating teams spent considerable time and effort searching for or developing their own tools for chronic illness care. Second, some teams felt intimidated by taking on the whole model and asked for a sequence to implement it. Third, many changes inspired by collaborative participation were made in ways that were clearly not going to be sustainable, such as manual entry of information on patient visits, lab results, treatment information, medications in the registry. Fourth, collaboratives can be expensive, which often limits their availability. Even when available, only a few individuals from a certain site can participate, which may impede the ability to reach critical mass in the clinic and transform the whole clinic in their practice. To address these barriers and challenges, I led a project in collaboration with Dr. Ed Wagner to develop a comprehensive toolkit containing guidance and tools for implementing the chronic care model. I also authored a companion coaching manual that described a low-intensity, time-limited coaching model to provide implementation support for chronic care model. The toolkit and the coaching approach were tested in Santa Clara Valley Health and Hospital Systems and in San Mateo Medical Center, The study would directly test whether the sequence model and the toolkit that teams asked for would work in the real world. 9 outpatient practices in the 2 hospital systems received the toolkit and coaching intervention. They tested more than 50 ideas, including using an action plan to empower patients to follow through their visits and use their medication, sending them letters to remind them of an upcoming appointment and get their lab before they come to the visit, and generating reports from the patient registry to see how the patients are doing and what patient to follow. We also found that the 600-page toolkit itself was used minimally due to its size and the clinician's lack of time. Coaching, in contrary, was perceived favorably. The coaching cost approximately $41,000 for each of the 2 hospital systems. Patients' emergency visits and hospitalizations were significantly reduced in the intervention group compared to the control group in the same clinics. From these experiences, I learned that the healthcare providers are interested in engaging in team practice for population-based care management and in using a patient registry to identify and help at-risk patients improve self-management of their chronic diseases. One challenge for the providers is that oftentimes chronically ill patients are also suffering from depression, but the providers lack the resources to screen patients for depression and to monitor depressed patients. Depression is a significant societal challenge because it worsens health status and outcomes, impairs productivity, increases health care and employer costs, and elevates risk of suicides. Thus, I'm currently conducting a subsequent study with the Los Angeles County Department of Health Services led by Dr. Katz, who will be speaking later today. In Los Angeles County, of the approximately 200,000 diabetes patients cared for by the county, about 30% have depression. My study used an automated phone call system for depression screening and monitoring and generated automatic reminders to inform providers to follow up with patients in need of attention. 1,400 of the county's diabetes patients are currently participating in the study. 1/3 of them, who are high-risk and high-cost patients, receive periodic phone calls to monitor their level of depression, check their adherence to treatments, remind them to exercise and do fun activities at home, and identify whether they need to reach a healthcare provider. These calls allow patients to choose their preferred language and call time. The call results are integrated into the county's Advanced Disease Management Registry. The registry tells the provider if a patient needs follow-up because they have persistent depressive symptoms despite of treatment, or poor adherence to treatment, or patient just confused about their care plan. Patients with suicidal thoughts are identified by the phone system. The system will automatically inform a psychiatrist within 15 minutes to contact the patient and consult them. The results are encouraging. Patients who receive the phone calls are less likely to have depression and take better care of their diabetes symptoms. The cost of this program is about $1.3 per patient per year. In conclusion, I have 3 recommendations for government-funded healthcare organizations to deliver outcomes in medical homes. The first recommendation is that all healthcare organizations should use the chronic care model to patients, so patients receive coordinated and planned care that help them with the information system that help them make better decisions. My second recommendation is to have the California's primary care offices located within the Health Care Workforce Development Division of the Office of Statewide Health Planning and Development to provide coaching support to public-funded healthcare clinics to help them learn and practice the chronic care model. The third recommendation is to apply the automated telephone monitoring system in medical homes to periodically screen and monitor patients for depression. One clinician who is in my current study in Los Angeles County told me she loves the system. It helps her identify those patients at high risk for depression, monitors her patient population, and reminds her to take care of patients at the right time. I believe these 3 recommendations will help our state deliver better patient health and lower healthcare costs. Thank you.
All right, well, thank you. Thank you so very much for all the speakers. So now I'd like to open up for questions for this panel. Yes, Ms. Bonilla.
I'm not sure if you referred to this, but something that I've been very interested in coming from the county, a county board of supervisors, is IHSS, in-home support services. And I think there's tremendous potential. I'd just like you perhaps to touch on what you see as the possibilities there. It's a very overburdened system currently, really fragile, yet so vital. When we think of the quality of life issues for someone receiving in-home support services versus nursing home and the cost savings of folding in-home support services to this model, maybe one of the panelists could comment on that, because I think that's critically important that we achieve a stabilization of our in-home and maybe even a broader vision of what in-home support services could be.
So clearly this is one of the hallmarks of what's going to be attempted as part of the Coordinated Care Initiative when dealing with the dual population here in California. The models of care that we have seen that have been highly successful in using IHSS-like workers in the home have really tried to integrate them into the care team, so that these folks become not only the primary caregiver in the home, but they're also the eyes and ears of the care team. And by incorporating those individuals into the care team, and you're going to hear a lot more about these teams, et cetera, that is going to be one of the potential opportunities, I think, in really thinking about creating the comprehensive care team and starting to integrate pieces of the healthcare delivery system that have been really fractionated and bring them together in a patient-centered way. I hope that answers your question.
Yes, Ms. Atkins.
Thank you, and maybe this will come up at another panel, but given that the foundation and the RAND Corporation and all these folks are looking at our system and how we're going to move to the Affordable Care Act and implement it. And, when I look and see a total of $635 billion on disabled and chronically ill, and you break it down into the duals and the non-dual, Medicare, blah, blah, on down through your point. And then as you were speaking, Doctor, and I didn't get to write everything down from the slide that talked about identifying the population, stratify the approach, clear articulate goals, systematic targeted, and then I lost the PowerPoint. But here is my question. We are looking at all of, you look at diabetes, heart disease, in the scope of the $635 billion problem. Where do we look at the cost to our system on the chronic homeless? Chronic homeless, not to be confused with chronic conditions, although the chronic homeless tend to have chronic conditions. And so I want to see, as part of some of these, I don't know what you've done in terms of looking at these different populations, but if we don't single out that category of people, much like we're doing the African American population or the Asian or whatever groups, I want to know how we're going to be effective, particularly since the cost of chronic homelessness in our hospitals, and maybe there will be some leverage to do something about that related to the 30-day readmission thing, which will force us to have to address it. But I'm just wondering, are any of the surveyors or studies, are you looking at chronic homelessness in terms of how we're going to address that as a population of people?
We actually did a whole project with about 8 counties on what was called the Frequent Users Initiative, where we were targeting the frequent users of the emergency department, which were primarily the homeless, or the homeless was a very significant population within that. What we found clearly is that it's the stability of housing and their ability to get that into place that then allows you to do the medical interventions a lot more effectively. Bottom line is, it's about the data, right? So we're currently out there surveying who are the number of homeless. Are those data systems at all connected to what we do in terms of healthcare costs, et cetera? Currently, no. And so that is another part of what the foundation is working very hard to do, which is to frankly free those public sources of data and figure out how do we create that literal map of understanding who the population is, what they look like, what they need, in order to start to match the services more appropriately.
I want to add that in our trial, which is 1,400 patients, that about 22 of patients who are most likely to be suicidal, those, a few of them are persistent suicidal intent, are the ones that lost their homes recently, live in a car, homeless. So I do want to echo that the ideas of that chronic illness also need to address patients who tend to at risk for become homeless, or homeless is going to affect a chronic condition. These two kind of go hand in hand, and when patient gets worse, they become suicidal.
Can I add just a little to that? You know, we have a huge homeless population due to people that have mental illness. Mental illness is not necessarily recognized as a chronic condition. It's a very big chronic condition. It needs to be looked at that, so we're looking at the whole wellness of the whole person. And until we do that, we're still going to have a system that's fractured, and the care that is necessary is not going to be addressed.
Mr. Amiano.
Good. We have a psychic hotline going here because you're addressing real things. First of all, thank you for that question, Assemblywoman Atkins. It's an excellent question, and it is a big concern. And the mental health piece, maybe I need a clarification. When you first introduced this, you said that probably mental health would not be folded into this. Is that what you meant, or maybe I heard it
data
different?
did not include mental health data because they're completely different silos of
Okay, but I mean, obviously, holistically,
yes,
you would,
from a patient
yeah,
perspective.
absolutely. And then when you get that data in regard to the homeless, the survey you're doing, she is Ms. Atkins is chair of our select committee on home. I know we would like to see that. We have some
This is not
legislation.
the California Healthcare Foundation. This is the statewide.
The statewide, okay, all right, because it is a demographic that everything.
Okay, well, thank you so very much, and I really appreciate the presentations and laying things out for further discussions, and I think certainly brought out some of the challenges we have in putting together the kind of data we really would like to look at to try to capture the whole problem. So thank you so very much. Just to remind everyone, we do have copies of all the slides in your packet, so in case you need to make reference to that. Our second panel is on the evidence and experience for the patient-centered medical home, and we have come up here Dr. Kevin Grumbach from UCSF Patient-Centered Primary Care Collaborative, Dr. Jean Rott, who's Chief Executive Officer at Sharp Community Medical Group, and Dr. Dale Bishop, Chief Medical Officer, Health Plan of San Joaquin. And again, we're going to be focusing on the patients, first with Dr. Grumbach on principles and evidence-based elements of the patient-centered medical home and outcomes measurement. Thank you, and welcome, Dr. Grumbach. At least no academic physician, right?
Good afternoon, Chairman Pan, members of the committee. I'm Kevin Grumbach from University of California, San Francisco. I'm a professor there and chair of the Department of Family and Community Medicine. And in addition to doing health services research, I still practice as a family doctor at the Family Health Center at San Francisco General Hospital. In addition to all the members of the committee and my appreciation for your attention to this issue, I want to acknowledge Assemblyman Amiano for his role back as a supervisor in sponsoring the Healthy San Francisco Ordinance, which I still appreciate every day that I go to work at San Francisco General Hospital and the advantage it's conferred on our things. So now,
by the way, just Dr. Pan and I'm going to be taking on a tour of Healthy San Francisco in the program. So
good. Well, I'm welcome to tour you around Family Health Center at San Francisco General. So let me get down to the business why I invited me, which is not to wax nostalgic about one county's approach to trying to improve access to care, but to really talk about some of the evidence on the patient-centered medical home. And I'm going to emphasize about 7 key take-home points I wanted to share with you today. So this is a first observation. So all this talk about chronic care and patient-centered medical homes is fundamentally about the primary care foundation of a well-functioning health care. So I just want to make sure that point is clear. So there's abundant evidence now from research in the United States, across the globe, saying that systems that are built on a solid foundation of primary care are much better able to achieve the triple aims of better health care, better patient experience, and lower costs in an equitable way. The problem is our system looks a little bit more like this rather than one built on a solid foundation of primary care. This is a report from the Government Accountability Office a few years ago talking about how primary care indeed, based on the research, is key to a well-functioning health system, and that our health system is completely topsy-turvy with a sort of many decades investment in specialty and high technology care with a relative inattention to the foundation of primary care. And you can see this at some data looking at Medicare beneficiaries by each state in the United States. And this is looking at quality of care where higher quality is here. This is a number of primary care physicians adjusted for the size of the population. What you can see, states that have a more primary care oriented workforce do much better on basic quality of care for Medicare beneficiaries, whether it's flu shots, beta blockers after heart attack, and so forth. And you see California falls right in the middle here, here on the sort of quality and on the physician supply. And the interesting thing, though, is the costs go in the exact opposite direction. States that have a more primary care-oriented workforce and the physician side of the workforce have lower expenditures per Medicare beneficiary. So you get, that's what every legislator's goals is, right? Better quality at lower cost, which you tend to find in systems that are built solidly on a primary care orientation. Second point I'd like to make, the first session focused on chronic care, which I know is one of the key things you're paying attention to. You have to appreciate that most chronic care is delivered in the home. It's patients and their families dealing with it. But in terms of formal medical care, the majority of chronic care happens in primary care settings, not in specialty care settings. So these are data, national data, and just say what percent of all visits to a doctor's office in each of these conditions occurs in either a primary care office or a specialist office. So you see hypertension overwhelmingly managed in primary care offices, diabetes, heart disease, emphysema, which is COPD. So you're never going to tackle the chronic care challenges for the population of the state unless we're focusing fundamentally on what's happening in primary care, because that's where the action is in terms of where the improvement happens and where patients are getting their care. Third point. So primary care is important. It's where most chronic care happens outside the home. And at the same time, our foundation is crumbling. We have half as many graduates of medical schools, whether they're in California, United States today, going into family medicine, into adult primary care medicine, into geriatrics, as happened 15 years ago. The one primary care specialty that's hung in there, I believe it's your specialty, Dr. Pan, pediatrics, which I think just as cheerful people who are dealing with children day in, day out. But largely it's because of the rise of chronic care and the increasing challenges as well as the compensation difference between primary care and specialty care that primary care has been a much more challenging and frankly less attractive to people with lots of options coming out of medical school. We have over a quarter of, actually only about a quarter of counties in California, based on some research we did a few years ago, sponsored by the California Healthcare Foundation from Dr. Chan's foundation, found that only about a quarter or so, a third of the counties in California actually have a minimum standard that the federal government would consider adequate for the population needs in primary care. We just talked, you asked a question, I think, Assemblywoman Atkins, about homeless populations. There's this phrase now, medical homelessness, which is just people cannot find a primary care physician, nurse practitioner, physician assistant because the workforce has fallen so far behind. And then finally, primary care has not actually done a good enough job in adopting the kind of model that Dr. Wu talked about, the chronic care model, and really think, how do we bring primary care into the 21st century to address these growing population challenges? Next observation. So if we're gonna move into this era of health reform with January 2014 rapidly approaching, we're going to have to solve the primary care predicament in the state. And this has not been lost on our federal leaders. The president gets this. This was a statement he made spontaneously at a town hall forum. This was not a scripted speech before the American Academy of Family Physicians. This was him answering a question asked by actually an elder person with chronic illness at a town forum and saying, folks, if we don't start building the system more around the idea of basic family doctoring, we're never going to really get to where we need to go as a country. This is not just a Democrat issue. I believe we still have some Republicans on this committee in California. And this is a bipartisan issue, really. I think Senator Orrin Hatch made one of the more profound comments in all of healthcare reform hearings that I tuned into, saying, this is a fundamental indictment of our American healthcare system by the ranking Republican on the Senate Health Committee, saying we need to focus much more on a preventive primary care orientation and not focus exclusively on how we rescue people after they have the chronic illness and are so sick that they're in the hospital. The Affordable Care Act has a lot of measures. I'll just leave this in your handout. So the federal government realized that if we're going to expand coverage, we have to rebuild the primary care foundation in order for people to actually get the care that we're promising under expanded coverage. And so we're at this point now where the key challenge in primary care is this transformation of how we deliver care. This is what it's going to take. It's not practicing your grandmother's primary care. It is new models of primary care, the chronic care model, other transformative ways of delivering that are going to meet the needs of your constituents and also transform the model so it's now going to be a much more attractive career for people going into primary care. So this is what we talk about with this era of primary care transformation. And you can call it, there's a lot of names, a patient-centered medical home. I'm not sure that's a perfect name. Do you know what people say? You know what the public, if you ask, do you ever go to your constituencies and say, have you ever heard of the patient-centered medical home? People, it's sort of jargon. One patient, when somebody did a focus group, said, oh, I get it. That's like, medical home, nursing home, and then funeral home. Is that the way it works? So it's not so much it's a place or something. It's really about a new model of primary care. You can call it advanced primary care. I sometimes just call it high-performing primary care. But it's much more accessible care, meeting patients where they are, engaging patients as part of the team, much more team-based care, I think, as you mentioned, Assemblyman Amiana. So these are the core elements. Patients, first of all, have to know where their home is. The idea that every patient should actually know who is the primary care team responsible for their care. So that's a key part of it. Not the old gatekeeper idea where it's to keep people out of the, away from services, but who is their advocate, who is their navigator through this complicated system. Team-based care. This is a team sport. Somebody mentioned IHSS workers, I think Assemblywoman Bonilla. This is about, it is everybody. It's not just the doctor, not just the nurse practitioner, PA. It is, how do you think about the home care aide as part of that team? How do you think about your medical assistants as having a role in chronic care and preventive care and educating patients and working with them? How do you get everybody at the top of their game so physicians are doing physician-level work, nurses are doing nursing-level works, allied health workers are really integrated in the team, and that the patient is fundamentally at the center of that team. Enhanced access. How many of you get frustrated trying to get an appointment with your own primary care things? The idea, you call, you get an appointment. You need a service. Everybody should be able to get it when they need it, the same day if they need it, within 48 hours at the latest. Maybe you don't actually need a visit. Maybe what you just need is a phone call. Maybe you should get it online through those of you who are using things like MyChart and the Kaiser system. So it's bringing care to where patients need it in an accessible way. Coordinated care, which is what the first session focused on, is how do you link patients, and this is where primary care is the integrating function as they transition out of the hospital, as they get home care services, as they move into palliative care. You need some central coordinating force, which is what primary care is really doing with patients and their families. Tracking and feedback, again, Dr. Chan mentioned that, the chronic care model. And then the final thing you need to do is pay differently. Because we're sort of stuck with this old fee-for-service model where the only time I get paid as a family doctor traditionally is if you show up in my office. And it's only if you see me. It's not if you see the medical assistant or other personnel. So you have to rethink the models. And most of these payments include fee-for-service, but something like a small capitation that pays for all that out-of-visit coordinating function so that if I'm spending a half an hour talking to the home care team, to the palliative care team, to the pharmacist, or if they're seeing a health educator, that all is compensated, and there's incentives to do this comprehensive care. So what I can tell you is this works. This is not an abstract notion. We reviewed a bunch of the data from published literature, from health plans that are unpublished, internal documents. I think, Cassie, you may have updated this in your report, or somebody did for the team, for your committee that has some newer data, and I'm going to go through some. They consistently show very good outcomes. So the document I'm referring to, we reviewed 14 different patient-centered medical home initiative. over 1 million patients. It's private systems, it's Medicaid programs in different states, it's the VA, it's a whole variety of settings. So it's working for a variety of populations. And what all these studies show is quality is better, access better, patient experience is better. And at the same time, partly because it's better quality care, particularly around chronic care, keeps people out of using the emergency department for needs that don't need to be in the ER. They keep people out of the hospital for asthma that's worse, for heart failure that's worse, for diabetes that's not controlled. And in fact, you pay more for primary care because it costs more for better primary care, but you recoup the savings in terms of less use of acute and emergency services. And these are just some of the examples. Group Health Cooperative, 5% reduction per member per month expenditures. Geisinger, the VA. Medicaid, you'd be interested in a couple of Medicaid programs, North Carolina and Colorado. Again, very substantial reductions in Medicaid expenditures by implementing this type of primary care-oriented, patient-centered medical home care. Since we published that report, there's been a bunch of new studies that have come out in the leading health policy journal, Health Affairs, that show, again, this is a WellPoint, the sort of anthem sort of lead corporate entity showing gains, Colorado, Horizon in New Jersey. Just across the country, you see the benefit. And here's some more data. And then WellPoint's conclusion, basically from their pilots, is this is what WellPoint thinks should be the standard in all their WellPoint Blue Cross model plan. Now, the trouble is, where have we been in California? You know, I didn't show you any of those data for California. Single payer, I'd love to come to another hearing, and I'd be happy to talk about that. But, you know, we have not had an articulated strategy around primary care that actually is true in Michigan, it's true in Delaware, it's in other states. And I think this is part of the things, Chairman Pam, for your committee to really think, how do we articulate a California strategy around this? It's a little embarrassing. You go across the country, all these are listed on the national website of where are there patient-centered medical home, multi-payer initiatives with state Medicaid programs, with private health plans, and you see a big absence here in California. We did not apply in California for things like the CMS Comprehensive Primary Care Initiative. We left millions of dollars in federal matching dollars on the table because there was not an initiative that would bring people together across the private plans to Medicaid to mount a state application to something like these Medicare initiatives. Now, until now, and I'll leave Dr. John Rett, we'll talk, we have finally now have a multi-stakeholder coalition in California, go by the name California Advanced Primary Care Institute. I'm participating in that, Dr. John Rett. We have leading medical groups, health plans, Primary Care Association from the state community health centers. So I think we are poised now to think, how could we work with the state and state government to try to do something? So, of course, you can't speak, and even though you didn't ask me to give my opinions, just the data, please. It would be a great wasted opportunity not to just share some opinions about this. This doesn't represent UC or CAPC. This is Kevin Grumback. I mean, first, you need to attend to the workforce. I mean, you can't have nobody home at the medical home. So, you know, you have things like the Song Brown program, you have state loan repayment. I mean, these are critical to providing the inducements and the support to build the primary care workforce. I think those deserve your attention and support. You have these exchanges that are going to start in January. I think trying to think how the regulations for the state health exchanges really incorporate the patient-centered medical home, advanced primary care initiatives, so that any plan offering a product in the state exchange really is delivering a product that assures that every beneficiary in that plan through the exchange is going to be guaranteed high-performing primary care, I think is important. Multi-payer initiatives. How do you align Medicaid, get the feds to buy in with Medicare, their matching funds, and state private plans? I think the private plans have come around, and I think they would love the idea, would the state help with some convenings? There's ways this can be done legally within antitrust. Actually, you're better off with state doing this than the feds doing it, because there's more exemptions for antitrust when state organize these sort of organized multi-payer coalitions to think about how to do the primary care models. How do you work with your state, your county Medi-Cal managed care plans? I know Dr. Katz will talk at the next session from LA, but how do you really support your county-based Medi-Cal plans to ensure that they're supporting primary care? And then one of the things that I was involved in with the Federal Affordable Care Act was a primary care extension program, which is really how do you create a statewide network of technical assistance to help your small practice in each one of your districts that are struggling with how do we implement change. We want to change, but how do I get into new models of access, chronic care model. And this is the idea like we do in the California Cooperative Extension for agricultural extension that's run through the state, UC, county governments. How do you have an agency in every county that can help practices make the transition to advanced models? And that's, again, something that there's federal money that can match state money, private plan money, county money. A little money can really be some of the catalysts to transform care. So those are the things that I wanted to share with you, and I really do appreciate you inviting me to share some of those ideas and evidence with you. Thank you.
Thank you. Thank you so much, Dr. Dornbach. And, I think we do have in Appendix A actually the updated charts from your report in terms of the different evaluations. Okay, Mr. Amiano, briefly.
Thanks. Appendixes are vestigial organs. Just a clarification, because sometimes we use old terms for new concepts. So geriatrics. I know there's a shortage of people who. So how does that term, what we mean by that term, currently fit into this?
So there's clearly the aging population is driving a lot of what's going on with chronic care. Sometimes geriatrics will function as primary care, but most elderly people are cared for by adult general internists or family physicians. In the role of geriatrics, there's no way that geriatricians are going to care for all the elderly as their primary care physicians or geriatric nurse practitioner. So they will do some of that, but their role will be increasingly to support generalists, family doctors, general internists. So I don't think the answer is just let's train more and more. We need more geriatricians, but you're going to have them work hand in hand with generalists in primary care in the nursing and physician field, which is where people will continue to get most of their care. Is that a help?
Yeah, no, yeah. That's good. And a lot of it to me is a good diagnosis too, as well. And I mean, sometimes there's competitiveness about so I imagine that dynamic is.
Yeah. In primary care, I got to tell you, there is so much need and so much demand, and we have such a slender workforce. We need a lot more nurse practitioners. There is less competition there in turf battles. There's some, but
scope. It's always
scope. And scope. And again, I tell you, the goal is get everybody operating at the top of their sort of skill level and license level, so that we can make the best advantage of all our human resources in healthcare.
Mr. Hernandez.
Thank you very much, Mr. Chair. Dr. Grumbach, you talked about maybe possibly sharing some opinions. I certainly would love to hear maybe what you would think are the top 3 obstacles or variables in play here in California that visibly, per your slides, keep us at a comparative disadvantage or comparatively well behind the curve. It's disappointing. It's embarrassing for our state to be so far behind. But I know that you, as an academic, you've probably have come up with maybe some of the high-frequency reasons as to why we're there. We'd love to know.
Thank you for asking. We should be the leader. We should be a state that knows how, as we do in so many things. I think one thing that happened, and Dr. Jeanrette may be able to speak, we got a little complacent with managed care. We said, well, we don't need this patient-centered medical home. We've already done managed care for Medi-Cal. We've done a lot of managed care, which has been beneficial, and it gave us a complacency. And we said, well, don't people have primary care? And I think we forgot we've not invested in the workforce to fill the managed care. And that managed care has gotten us so far, but we now need a quantum leap forward. So I think there was a complacency partly around, haven't we already done some of this? I think there was a lack, I think the budget predicament set us back, so there was a tentativeness about new initiatives and not taking up even federal matching grant opportunities that the state could do. And I think there has not been a champion, frankly, at the state government level, who I think Senator Hernandez on the Senate side is doing, I think now with this committee. But I think there's a tremendous need for leadership to step up and really declare this as a key issue that the state needs to focus on. And I think the third obstacle was you didn't have willing partners. You did not have private health plans until now that were really willing to do this. You had a question among the medical groups, whether it's Permanente Medical Group, whether it's Sharp-Steele, which is a Sharp group, which Dr. Genretto talked about. And I think we're in a very different place through this California Advanced Primary Care Institute. So I think the environment has changed. I think there's a realization we got to get over the complacency. There's an embarrassment that other states are now moving ahead of us. And I think there's a real desire for a focal point at the state government that says we will really hone in laser-like on the primary care needs, the coordinated care needs, and then bring together different stakeholders that traditionally haven't worked so well together and say we really need to work together in a much more collaborative fashion. And I think you would find tremendous willing partners, and I think all of us who are trying to build these types of stakeholder coalitions on the private sector or academic side would love to see some collaboration. Is that helpful?
No, it does. Thank you. I think that's a good answer. It's helpful to me. But I think even if we're looking at just a bottom line concern, whether it's private sector or public sector, getting up ahead of it, getting in front of it, being preventative, and maintaining that preventative activity undoubtedly is going to save our societal costs, our cost pressures on whether it's private sector trying to limit their cost or us as government trying to spread our resources more effectively. It just seems like the best way to go.
It's a great return on investment. You can't say that. I mean, primary care is a great investment. It's cheap. It's relatively inexpensive compared to building all the new hospitals and everything else, and it actually has positive return on that investment.
Great. Thank you.
I think, Drs. Jonrat and Bishop are going to give us some actual examples, which I think will be very informative. So I'm just going to let one more question, and then let's try to finish through the rest of the panel, because I think it's going to be very illuminative, and then we'll reopen up for the whole panel for questions. So, Senator Mitchell, do you have a question?
I just wanted to respond in part to Mr. Hernandez's point. This House took up the issue of health homes last year, AB 2266. It came before this committee and it passed out successfully, and I'll be reintroducing it this year. So I think there's probably, I would have some additional reasons why we were not successful in addition to your list, some internal, some external. But I look forward to this committee and Mr. Hernandez in supporting the concept and our effort in trying to get it through one more time.
Educated too a little bit more about some of the good efforts you've had here.
Well, thank you. Dr. Jonrat.
Yeah,
welcome.
Thank you so much, Dr. Pan and the Assembly Committee on Health. It's a pleasure to talk about primary care, its current successes, and where I think it can actually go in California. And before I even focus on what I was going to talk about, I can't help but weighing in on what we see in California and the perceived kind of lack of primary care. I want to emphasize, I think that Kevin pointed out well that the alignment of incentives in California had been very strongly within the commercial market and Medicare Advantage around prepaid capitation. And so when those dollars already flow to you, you would anticipate that you're producing very good primary care services. And in fact, many of those organizations have done a lot with chronic care management, a lot with disease management, and have whole programs that are outreach and calls and readmission prevention and taking care of complex and transplant patients. So there's been a lot of systems that have been put into place. And so a very large portion of our population functions under that kind of a helmet, so to speak. And so I think it's true, as Kevin was saying, the individual payers were saying, look, we're already paying you. This is half of where our budget is. And so there wasn't the same initiatives in California as across the country to say, how do we improve cost and quality in California? And so the payers weren't stepping up to the plate and saying, how can we change the rest of the payment incentives, those that are fee-for-service? That PPO population and others. So we really have a very mixed bag, and we could go into further discussion about why we look the way we do in California. But what I wanted to really kind of have an opportunity, I'm excited about primary care. I'm a family physician. I saw patients for over 20 years. I also directed a family medicine residency program, so I trained medical students and residents. And I'm very excited about the opportunities we have in California and in some of the current roles that I play, both as chairman of the board for CAPG, the California Association of Physician Groups, as well as the CEO for Sharp Community Medical Group. And so I just want to really quickly show you Sharp Sharp Healthcare because I'm going to try to bring it down to what does it look like for the providers? What are we doing in the community? You're hearing a lot about this chronic care. How does it play out? How does it play out locally? So this is Sharp Healthcare, an integrated delivery system, hospital systems, medical groups, a Sharp Health Plan. I'm not going to go into any of the detail. I represent Sharp Community Medical Group with over 600 physicians, multi-specialty group. The two organizations at Sharp take care of over 325,000 HMO patients. In addition to that, probably another 360,000 PPO, Medicare fee-for-service patients. We also have 32,000 of Pioneer, the Pioneer ACO, one of the 6 in California and one of the 32 across the country, and take care of another 30,000 commercial ACO patients. And I point this out because our methods of delivering care and providing services very much align with the chronic care models that you've been hearing about this morning. CAPG represents 155 of the top medical groups in the state. Innovation, forward thinking, doing lots of work around primary care, lots of work about chronic care management, taking care of over 18 million Californians, that's half the population, 2.5 million seniors in Medicare Advantage. 6 of the pioneers are within these 155 groups, and another 20 shared savings are part of the 155 medical groups of CAPG. So I did want to spend a minute talking about CAPC. I thank Kevin for teeing it up, the California Advanced Primary Care Institute. We are excited. It's a big tent approach. We have, we think, the right people at the table. As you can see, the Military Health Systems has been with us. I had an opportunity to visit a few of their ambulatory sites. Fantastic work that they're doing around patient-centered medical home and how they're creating the team-based approach to care. Our community clinics are involved, our academic centers, our primary care academies, the Physician Associates Academy, the California Academy of Family Physicians, many of them at the table, health plans, employers' purchases, PBGH, and we have our state and federal government representation as well. It really is the first, I think, opportunity in California to have the right people at the table. Many have tried, many have failed, because I don't think they keep everyone in play and at the table. I bring this to you because I think this is a great partnership opportunity with the Health Committee, that I think we can be of assistance, we can be a trusted resource, and we can help move this together. And so I wanted to take a few minutes to highlight that. The 4 Ps of CAPC, easy way to remember it: the pipeline, the practice redesign, payment, and policy. Pipeline, how do we get the medical students, the NPs, the PAs, the pharmacists, and others interested in primary care? What do we do with practice redesign? How do we change to the patient-centered medical home team-based approach to care? Payment, how do we align the rest of the payers? How do we align these payment systems to make sense? And policy, meeting with you here and others in Sacramento around the focus, and again to provide that education and resource. So those are the 4 Ps, and hopefully we'll be talking with you a lot more. What I wanted to focus on then primarily was the care transformation model, clinical integration. Dr. Pan said at the beginning he wanted to answer some questions about how does this fit into the Affordable Care Act, and I think I'm going to be able to show you. How does this improve quality and save health care dollars? And I think this model will demonstrate that. What kind of patients benefit? All patients who access a system of this kind of care will benefit. Unfortunately, not all patients have access to this kind of care, and that is one of our issues. So if I begin with the clinical integration model, what we begin with always is the patient and family. And this is about how we engage the individuals. These are the things: personal health records, our health risk assessments. Again, we talked about the creation of registries. Remember identifying those patients? So how do we identify the patients? How do we communicate with them? Portals, smartphones, other ways of communication. Surrounding the patient and family then is advanced primary care. I call it advanced primary care instead of patient-centered medical home because I think it's more. I think advanced primary care says that it's supported by the group and the structures. The information that Kevin presented often showed that they were supported by groups like Geisinger, the VA, and other organizations that were supporting primary care. It wasn't primary care out there alone trying to make this happen. It doesn't work. They can't do everything. They need support around them to make primary care viable and to work well. So under the advanced primary care model, these are the things that go on in primary care. Prevention and wellness. Point of care analytics. We have EHRs that give physicians reminders about what's missing in healthcare. Right here, registries. Dr. Chang talked about registries and population management. Generic prescribing programs, our team-based approach. I won't read through all of these. We're looking at access, same-day appointment, e-visits, how we engage the patient. And the interesting thing about this is the patients are happier, the physicians are happier, and the staff is happier because what they're providing is really good care and comprehensive care. Surrounding the advanced primary care, then, is the medical group or enterprise-level activity. So Elliot Fisher kind of coined the medical village, and so how do we take it further and support primary care? Well, this is where you see organizations who are actually doing incentives, pay for performance, providing hospitalist services. This is where care management is embedded into the practices, or special services or home services are provided. Health coaching, and where we look at end of life and palliative care and transitions. And this is where behavior and mental health, we are now beginning to embed behavioral health specialists within the practices to deal with it up front while the patient is being seen in the office. And the final level brings you into the accountable care organization. So many people get confused and say, well, what's this patient-centered medical home? What's the ACOs and the ACA? How does this all fit together? And in the model, and I think this is true across the country, and if you were to ask anyone in medicine who is doing this, the patient-centered medical home is at the core. It's embedded within the ACO. The ACO is then taking it to the next level to look at every element of care. So how do we manage, that's DME, durable medical equipment. How do we take care of patients in a skilled nursing environment, in the hospital setting, in hospice, in home care? We need to be able to overarch the entire care of the patient in the continuum, have that team-based approach focused. Primary care is the coordinator of all of that effort. So this gives you kind of the clinical transformation, or what we look at as what true clinical integration is and where we're headed for. I think it does advance better care, better costs, better outcomes. It absolutely lowers costs, improves patient satisfaction. I think it's enhanced when it is surrounded by medical organizations of many types. So I see that going on in military health systems. I see it in the community clinics. I see it in the private sector. It's the organization that surrounds it that makes the difference. And for me, it's the future of California, and I hope to work with you as we go down the journey together. Thank you.
Thank you. Thank you so very much. Thank you, Dr. Knott. Dr. Bishop, welcome, and someone who also represents part of San Joaquin County. It's a great pleasure to have you here. Looking forward to hearing your remarks.
Thank you, Dr. Pan, and also thank you to the committee for allowing me to speak today. I want to give you some experiences we've had in San Joaquin County with a pilot project to implement a patient-centered medical home over the last 18 months or so. And I'm going to set the stage for you as San Joaquin County once we get our, do we have the slides? Do I have to do something? Up top, yeah, there it is. So I'm the Chief Medical Officer for a Medi-Cal Managed Care Plan, and as Dr. Grunbach showed all that data about how there's all this great savings in patient-centered medical homes, which is true at these sites, we were very excited and been excited for some time about trying to implement one of these. The next, let's see. Some of the challenges that we have in San Joaquin County are that we have an underserved population, have a lot of poverty, we have a lot of disease. We rank 56 out of 58 in California County's 2011 health status profile for diabetes mortality. So we have a lot of illness, we have a lot of behavioral health issues, high levels of homeless. So it's a good spot to try to put one of these in place to see how they all work. Our provider population, Dr. Grunbach touched on this too, we don't really have enough doctors for the population, both in primary care and in specialties, and in our area we have a hard time recruiting people. Next, it's me. So partner organizations that are involved in this project basically are the public hospital with its family medicine residency, the county behavioral health program, and the community medicine, the FQHC in the area, and the health plan of San Joaquin. We had an opportunity in spring of 2011 to attend a Center for Care Innovation Best Practices on Patient-Centered Medical Home Conference, and we all attended that, and we were exposed to these different models, and we also had the opportunity to apply for a grant through the Tides Foundation for about $300,000 for 2 years, which we did and were awarded. From there, we used the funding to get Health Team Works, a consultant who had done the Medicaid, many of the Medicaid programs in Colorado used, or the Medicaid program in Colorado, many of the clinics used Health Team Works to convert their clinics. And they also had a lot of experience with family medicine residency programs. They seemed like a good partner for us to work with. From there, we, using their model, began the project in the summer of 2011. And basically, the beginning of it was training one of our nurses to be an expert to help coach the clinics to change their practice paradigm. This really can't be, I think, from our standpoint, understated. It's been a challenge to get clinics to go from a model where you're seeing 4 or 5 patients an hour and you're paid by fee-for-service to this model of having the team approach, which theoretically certainly at the beginning, kind of like electronic health records, slows the process down. So there's some difficulty making this transition. So having the consultant and the model really helped us. From there, there was a lot of work on getting the teams together, nurses, the medical assistants, and social services. And another thing that we've done, which was really important for us, was integration of behavioral health services into the clinic sites. It's been mentioned also by my colleagues. We have behavioral health on site in the family medicine clinic sites, and we also have, where we're piloting is putting family medicine practitioners into the behavioral health site. Behavioral health community is tells us that the people with chronic mental illness that's serious die about 25 years earlier than those without chronic mental illness, mainly because they don't get medical help. Often they'll see their mental health providers, but they won't get their preventive care and all the other medical problems they have. So there's definitely some gains to be had in having both primary care at the behavioral health sites also. So we also have been working on tracking of the care. The disease registry Dr. Chang mentioned, and also Dr. Grumbach, has been critical. Putting a disease registry in place at the clinic sites really, maybe almost more than anything, helped with some of the clinical results, which I'll go over in a minute. Then from there, consumer engagement, getting the patients to actually become part of their care plan, really to make them feeling like they're part of the decision team, having peer counselors work with them on chronic illness care has been also very important. And finally, aligning incentives, a lot of discussion about the payment reform. What we've done with this project is that the Health Plan of San Joaquin offers capitation with fee-for-service for certain activities. We also have a fairly robust incentive program where the primary care can make about 15% additional income through doing well with their preventive care programs, things like getting the diabetic testing done, getting people's sugars under control, getting their cholesterols under control. So all those things were part of the program. The final piece was the plan to share savings, which we haven't been able to do yet, but I'll talk about that at the end also. So that was the getting all the project kind of in order. The target population for this project is diabetic population with the Health Plan of San Joaquin, who basically are being seen at these clinic sites. There's about 1,000 in these sites right now, and the clinic sites plan to expand this to their entire population over the next few years. They're actually going to they're both seeking patient-centered medical home accreditation through NCQA and JCAHO. So they've kind of started on this road, and they're very excited at this point about continuing it. So, excuse me. So some of the objectives of this basically were to improve the care of the diabetes as measured by basically NCQA HEDIS parameters of diabetes. These include what I mentioned before, the blood sugar control, cholesterol control, testing for these things, and checking for both retinopathy or eye problems and nephropathy or kidney problems. So the plan was to increase those at least 5% over baseline. The other clinical parameters that were put into place were to consider depression. As it was stated earlier, depression is a critical part of caring for people with diabetes because many of them are depressed, and if they are depressed, their outcomes are worse. So we had a number of parameters in this project to increase the screening for depression, I think getting it above 90%, and then getting the treatments in place and having at least a 40 to 50% improvement of their diabetic PHQ-9 scores after they were on treatment for 6 months. So those are the clinical portions of that. We also have patient satisfaction measures, access to care measures, and then finally the cost and reimbursement measures that the health plans keep track of. So results to date, the results of this unfortunately are a little bit hard to interpret because during this same period of time that we did this, we're doing these clinic initiation, the seniors and persons with disability were assigned to Medi-Cal managed care, so our population basically changed throughout the initial 12 months of the project, such that the patients were actually much sicker once they were all assigned than they were at the very beginning. So to compare the cost at the end to the beginning up until June wasn't really fair because people had more needs, they were getting to the hospital more. But to kind of summarize the good news here, for the diabetic outcome measures, the HEDIS measures, basically all those measures have met goals. The physicians in the clinics and the teams have done a very good job identifying people, getting them in, again, using the team approach where people are all working together to help get this care accomplished. The outcomes for the diabetic care are very good. The control of their sugars is much better than it was before. All of the, again, outcome measures are at least 5% above baseline. Depression care is also significantly improved. It's meeting goals. So all of the clinical outcomes over about the 18 months we've been doing this are met basically at this point. We have about another 6 months to go to finish the program, but the clinical goals were great. So we clearly are using a disease registry, and this was, again, I don't want to forget about this, using a disease registry to give the physicians feedback about their results individually was extremely important, and the physicians could see on a daily basis how they're doing on getting their patients care given or preventive care done, and that was extremely important. The overall costs have not, at this point, decreased yet. We're still think the curve is starting to bend. Again, the complexity of the patients for the first year or so increased, so that didn't really work. One of the things that happens when you put people in a patient-centered medical home initially is when you do all this preventive care, you do identify problems. So for about 6 months, we've identified people who had things like breast cancers that weren't identified and all. So things like that do initially bump the cost. So we're not seeing within the first 6 months of the stable population a decrease in cost, but the cost curve is starting to bend. The good news is the emergency room rate of use has gone down significantly. It's gone down about 5%. And that's especially seen in avoidable ER visits, things like people going in for flu and colds and mild problems, skin rashes and things, because I think the same-day appointments, part of the access was to give a same-day appointment, so that's helped that a lot. So in summary, I think the pilot project so far is successful. Certainly clinically it's helped a lot. We haven't seen the cost curve bend all the way down to going downward yet, but it's flattening, and the ER visits give us a feeling that that's going to happen. So we're pleased at this point. Would be happy to answer any questions you have.
Great. Well, thank you, Mr. Bishop. So let's open up for questions actually for the entire panel. Mr. Sandy.
Thank you, Dr. Pan. And to anybody in particular, Dr. Grumbach had this, I guess to you maybe, you had a slide up there that quoted President President Obama saying that we used to have our doctors, our family doctors, now we don't. What happened? Why do we no longer have a family doctor?
So as I say, there's about half as many people graduating from medical schools going into family medicine in the United States or adult primary care medicine. Three main reasons. One, frankly, people are so in debt, and you can earn so much more as a radiologist or anesthesiologist that it's just economic logic for these students coming out of school who are $150,000, $200,000 in debt. I mean, you've seen even I went to UCSF when the tuition was a fraction of what it is now. So you're grappling with this in the UC system. So the payment incentives are so misaligned. I mean, we've rewarded so much doing more procedural, more technological things that it's just provided this great incentive to go into a lot of fields other than primary care. Second was just the models. People were overwhelmed with seeing chronically ill folks feeling like, I don't have the team support, I don't have the resources, I don't have the ways to do this. And I just as soon go do dermatology. I can see some rashes. I can go home at a reasonable hour and not be on call for all the patients calling in about their asthma out of control. So it's really a combination of the compensation gap, and then we just had not invested in this sort of revitalized models of primary care to make people think this is an inspiring job. And then the third fault is my fault. It's where I sit in academic institutions where the lack of prestige, the lack of sort of regard for primary care. You know, I can't tell you how many students when I was in training, and it still happens, we said, what a waste of a promising medical career to become a family doctor. You know, don't you want to be a specialist? So we have to change our culture at the medical institutions, including the University of California. And then you're going to have to figure out how to shift the payments around to reward primary care to close that gap. And that's where things like the loan repayment, the state loan repayments are critical. I mean, if you can wipe out your $150,000 of debt with a 3-year loan repayment through the state, that goes a long way to saying it's okay, I'm not going to make what a dermatologist or a cardiologist can make if I at least get rid of my debt. And then it really is making primary care seem like a doable job.
Dr. Jen Redd, if you're going to follow up on that.
Yeah, I think there's also a societal problem. I think it's, as far as everyone having a primary care physician, a lot of people don't want them. It's interesting. I mean, in the way that medicine has gone, we're all very much enamored with technology and the conversations, you know, in my parents' senior citizens' homes, or, you know, which specialists or who are you seeing? And so there's been kind of an attachment to the specialty kind of services as well. Many patients do, you know, they say, I see my cardiologist, I see my neurologist, I see. And so your initial question was, why doesn't everybody have a family practice doctor anymore? One, the capacity could be an issue, and two, I think it's society as well. We tend to drive our services towards specialty care, so maybe we haven't done a good job of showing how important it is, or how we need to establish that for everyone.
In a sense, I know I might have a heart condition, so I'm going to go see a cardiologist.
Right.
I'm going to go see.
Right. Correct.
And is it a problem, like, if you have in the model that you just talked about there? Do you get overutilization of the healthcare system? Are we afraid of that at all? In a sense that we're bringing a lot of people and we're treating them in a magnificent fashion, it seems. Is that a problem?
I don't believe it's a problem long term, but you have to look at the entire healthcare budget, because you are definitely increasing services and service level, patients coming in, access, chronic disease, you know, following them up very closely. But if you look at the whole healthcare budget, what you're really saving is on the other end. It's this chronic care management is that emergency room, and, you know, in our Pioneer, 67% of the hospitalizations came through the ED. How do we keep chronic care patients healthier, and how do we manage them at home? What would it be like if the end stage for chronic disease wasn't always the hospital? What if we were able to manage those services in a different environment that's less costly, and it's really where the patient wants to be managed? It's the shift of the dollars. So I'm not worried about the utilization.
Yeah, just to tag onto that, I think the patient-centered medical home is not where the costs are being developed, right? It's really the specialty care and the hospital.
I get it. So you might have a certain amount of overutilization, but that cost is far less than the other end that you'll save.
Primary care directly is about 6% of the healthcare spend, what goes on in primary care itself. So you know, you're right. You'll get a few more people with better access saying, let me go in with a sniffle that maybe but for every one of those, if you can save somebody going to the emergency department, you know, 5 of them for that, or much less somebody winding up in an ICU for a terminal illness where what the family really wanted is hospice care and home, but it was not coordinated in a way that people tuned into that. The yield is just phenomenal. So you could raise primary care spending by 50%. You could recoup that in you know, with a 1% change or 2% on the acute care sector expenditures. And that's your challenge. And that's why I said the incentives are so misaligned. I mean, let's just accept it's a zero-sum game. You don't want to spend more on the overall state healthcare budget, I presume. I think there's reasons that we spend enough. It's how do you shift the money to where you get better value for the spending? And I think the sense is in all our systems, you get great value in primary care. It's going to ideally mean less acute hospital cares, and that's where those savings come from in the budget.
One of the ways to control it also is if you do some capitation, as we have, the primary care doctors are creative and bright, and they can figure out ways to address patients without necessarily having them come in for a visit every day. You can talk to them on the phone. You can do e-visits. There's other ways to kind of meet their needs and not necessarily even have a physician call back. Someone who does, there are patients that just need to be called a lot or be contacted a lot, and you can have a medical assistant call them back as a health navigator or a social worker call them, and often that really meets the need and really saves the system a lot.
Yeah, thank you.
Okay, Mr. Chesborough.
Yes, Dr. Bishop, Health Plan of San Joaquin is what they consider a local initiative?
Yes.
Is that correct? Well, I represent a largely rural area, and I'm addressing generally underserved communities, but my primary concern is rural, but there's other underserved communities besides rural. And I'm one of the problems with the Affordable Care Act, I think, and we talk generally about the number of healthcare professionals available, but in underserved areas, that problem will be even greater because there's multiple factors that cause those communities to not have an adequate network of physicians. It's not going to do you any good to have access to a plan or some sort of insurance mechanism if there's not a network of physicians to serve that. What has been your experience in terms of the way local initiatives and county organized health plans, COEs, are able to address that question of making sure that there's an adequate network? Because we've had problems in rural areas with some of the larger health plans, offering a product, saying that they have a network, and in fact, when people start trying to find a doctor that'll take them, it's really hard to find.
It's definitely a challenge. We've had actually some good results with some pilots on telemedicine. Dermatology is a big problem in our area, and we do teledermatology, store and forward technology, where the primary care, we pay them a fee for service for this, where they take a picture of the lesion, describe what the history is, and send it on to the dermatologist, who looks at it later and then sends the primary care back within 48 hours of report. They also have to arrange some biopsies locally, too. But that can work very well for some of the specialty needs.
What about primary care?
Primary care is a problem. So you really have to promote primary care expansion into these areas. Without any access at all. You can do some things with telepresence Skype. When we've done a little bit with that, there's psychiatry can be delivered that way. There's some specialties can be delivered that way, but it hasn't been used to a great extent in primary care. And theoretically, without doing an exam, it's difficult to really make a diagnosis in many cases. So at some level, you're going to need to have some primary care, but you might be able to meet part of the need with Skyping or telepresence kind of functionality.
Is there anything about the mechanism, though, of a local county plan or multi-county plan that can has done better or has a better track record in terms of making sure that there's a greater network available in rural communities? What I understand to be the case, I don't want to put words in your mouth, but that the direct involvement of the provider community in a local plan tends to make the local plan more respectful and responsive to physicians' needs, as opposed to, large insurance organizations.
Right, no, you're right.
Don't have that same level of involvement.
It's really important to have physicians involved in the plan. We have tried to hold that model, and it's helped a lot. But there are a number of barriers to opening up clinics in rural areas. I think generally the FQHC model would tend to want to do that. However, I know over the last couple of years there have been a lot of additional requirements on building, such that it costs about $250 per square foot for these FQHCs to put a building in that can be used for medical care. So there might be some consideration of relaxing some of those requirements. I think there's things like the air exchanges per hour and the sprinkler systems that basically, talking to some of our local FQHC leadership, they say we really just can't afford to even put these clinics in, even though they're very interested in doing so.
Thank you.
Mr. Damiano.
Yeah, just following up on that, in terms of rural and particularly undocumented, there is that program, the Pomodores program, which sends people out, and maybe that's something that could be amplified. And this is just a small wrinkle, and your comment reminded me when you're talking about Skyping. I guess I read a story in rural South Dakota or something, and there's no service. There's no it's just one of those obstacles that we take for granted. So eventually, that'll have to change too, I imagine.
Proposition 1D, there's been a big advances in California with, I think, trying to overcome the telemedicine barriers. I think, Assemblyman Chesborough, I think, Dale, there's probably a lot of the things about pay issues, just family life and things like that, and when it's a short supply, it's tough to get folks. So I think, again, there's the state loan repayment, the rural kind of initiatives, but I think probably the final thing is, can you create a sense of the infrastructure for primary care, and then, as John was saying, the medical neighborhood, essentially a system, because the only thing, it's in addition to the compensation, the lifestyle, there's a sense, if you are alone there in a rural area and you need a specialist and you don't have a system for teledermatology, you say, why I can't practice good primary care here? Because my patients don't need just primary care. They need, access to cardiology and dermatology. So you need to think, are there then systems? And I think John was talking about in urban California, that often is a IPA-type medical group, or it's Permanente medical group, or it's a very strong primary care clinic network that has several sites and has the capacity to support that. I think this is, and you probably do some of that through your Medi-Cal plan, but for the private rural practitioner, the question is, can you create some infrastructure there? Could the state partner with the rural healthcare associations to say, we will think through how you do teledermatology when you don't have your Medi-Cal plan there willing to, be that conduit for the private sector. We will think of ways that you can have health educators and promotorists so you don't feel alone when you're trying to take care of, all these diabetic patients. So I think there's a real vacuum there because there's not the Kaiser, there's not the urban infrastructure, and I think thinking how can you facilitate that and then build the sort of team care, build the linkages through telemedicine, so a family doc out in a rural area could say, I could get what I need from my patients through this sort of virtual system.
And that really leads to my point that health plan structures that are able to incorporate the providers into the process so that there's more of a give and take and a dialogue about solutions that can attract and retain and help them to be in business in rural communities is a much more responsive model than one that doesn't have that same on-the-ground connection.
Thanks. Great. I also have a comment and a question. First of all, it's as a primary care physician myself in pediatrics, I think, and someone who's studied workforce, that I know that, and as a residency program director, I know that a lot of the residents who are coming out, they are concerned about how to balance lifestyle. And we say lifestyle, but I mean their family time and so forth. And if you're the only doc or you're one of a very small group of docs, you're on 24/7. And being a primary care physician means that you're always on. You get phone calls from people, you run into people in the grocery stores, et cetera. You are never off your job. You're always on your job. And a lot of people are looking for positions where you work emergency room, you work hospitalist shift, they'll work hard when they're there, but they want to be able to turn it off. And in some senses, I'd say the appeal of primary care is not so much that you're on all the time, but that the kind of a long-term relationship you can build with people, and that's really the heart of primary care, this ongoing relationship. But at the same time, you become responsible. You feel responsible for the people, so it gets really scary when you're out by yourself and you know that there's something going on, you're not sure what it is, and you can't get help. You feel like it's hard to get help, and that's why it's so important we build this infrastructure to support primary care. Now, as we talked about these different, model of patient-centered medical home, advanced primary care, I have to say, the reason I really like the term medical home, I know that sometimes it's a little obscure, but it's because one of my mentors, Dr. Calvin Sia, in pediatrics, the one who coined the term back in the 60s, so he is a mentor of mine, so I want to respect his innovation and his advanced thinking back in the 60s about our delivery of care before anyone else was talking about medical home, but we heard about your implementation, San Joaquin County system change, what happened, so forth. And I know that in our last state budget, we talked about coordinated care initiative, the Medis, and how we're immediately going to see state savings. But it also sounds like there's a lot of work to be put on. And I think we provided a whole appendix full of evidence for savings that Dr. Grumbach, that I think came from a report you did. But that only came about because people made investments up front to get the systems in place. So when we're looking at this, which we need these savings, we need to bend the cost curve. What should be our expectation in terms of, as we're trying to expand the patient-centered medical home, these models moving forward in terms of financially, should we really expect to either spend the same upfront for a year or two to do the transition or however before we expect this, versus saying that, well, we're actually going to undercut it by taking the investments away and tell people you just got less to work with, even though you have to now rebuild rebuild the way you do things?
It's a long flight path, and we've learned that the hard way in a number of different initiatives that we've done. There is a lot involved. I mean, when we just simply throw out here's a registry and here's your patients who need care, to get to that and to accumulate that data and be able to make sense out of it and getting it to the physicians is a very long flight path. Another example in the Pioneer ACO, and we've been at that a year, we're on to our second year. The amount of time and energy and investment that needs to be put in before you can begin to see anything is far longer than anyone would anticipate. So in supporting your statements, Dr. Pan, I think we all need to have the expectation it takes an investment and it takes a lot more time than we would hope. And you can't be saying, I'm going to do this and in year one I'm going to see this budget change. It doesn't happen that fast.
And from our experience, in addition to the investments you have to make up front to make the transition, I think you do have to anticipate there's going to be some expenses that are going to be borne by people who haven't had care that are all of a sudden in a good care system that things get discovered. There's a number of data from across the country about when Medicaid systems go from fee-for-service into managed care. There's usually a medical loss ratio of about 150% for the first 6 months, which means you're spending 1.5 times what you used to spend for the first 6 months while you're taking all this into care, all this care that was basically left go gets taken care of.
Okay,
just
Mr. Nasanti.
Follow up on Dr. Pan's comments. They've talked about the total cost of health care in our economy going from whatever percent to 17, 18%. Is that kind of what you just said? There seems to be an upfront cost, and there seems to be a cost because we're covering a lot more. And is it just a fact that we are going to spend more money as a percentage on healthcare because we have new and greater technology, we have new advances in medicine and so forth, that costs money? Or, and hopefully, obviously, we bend the curve, but are we really going to bend it that much, or do we just accept the fact that we will be spending more going forward in healthcare?
I think you're going to get various opinions on that, but I'm going to go out on a limb and say I think as long, when I compare to what the treatments that are available today compared to what were available when I trained in the 1980s are incredible, and the life-saving transplants and chemotherapies, biologicals that are available for disease are incredibly good. And I think, and I'm not putting any cold water on to continue developing those things. I think that's wonderful, but I think as long as we have these things, the costs. We can bend the curve for sure. There's all kinds of savings to be had here, and we can put off chronic illness for a long time, but there is going to still be a drive to increase costs. So ultimately, where did the balance come out? I don't know. Hopefully it does come out that we don't go up too much more than we are now. If we can do a really good job being efficient and preventing complications, we can bend the curve a lot and maybe flatten it. But in the meantime, you do have a driver of fantastic treatments that are coming out all the time that are going to continue to push up the costs. And often that isn't considered. We have these kind of meetings with managed care. We talk about how we can make the costs go down. I'm not so sure that you can completely make them go down when there's all these new treatments that are coming out, which are fantastic treatments for all of us.
I would just say that as a population, one of the things you mentioned and is so real, first of all, our costs are going to go up because of the changes that are going to occur with the exchanges. I mean, when we have that access, and again, we already can demonstrate to you when people first enter the system the first 6 months, the costs are going to go up because we have delayed care, we have other things that we need to pick up. If you have a stable population, and you've had time to kind of implement the programs and the chronic care management and end-of-life care and a number of the other things that a lot of people don't like to talk about but are real in medicine or the real cost drivers, I believe that we can actually hold the trend. Can we bend it a lot? Maybe. Technology is a big piece of that, but we have the opportunity. But in the short run, as we make these investments, as we start to turn things in a different direction, as we implement the exchanges, it's going to go up.
So maybe the question is, are you getting good value for what you're investing, whether it's 15% of GDP 17 or it goes to 20%? I would argue we're not getting good return for the investment we're making right now, and I think a lot of that is because we have not invested it enough in primary care. The This morning I rounded on hospital patients with our family medicine team, and I mean, just a perfect example. There's a patient with a low blood counts, and so the specialist recommendation will keep them in the hospital because we just want to monitor the blood counts. And I'm saying, no, they have a good primary care physician. We'll send them. They can come back tomorrow for a blood test. You don't need to just sit in the hospital so you can check a blood test, because they're in a system of care where they have a good relationship, and that person will follow up, and they can come back. And it's that switch of, like, there's all the stuff we do in the hospital with good primary care you don't do that is benefiting patients not a whit if it's exposing them actually to potential harm and cost and things like that. So I think that's another hearing. You talk about, maybe that's the single payer bill. I mean, what you want to do about global overall expenditures, but right now, our tax dollars are not getting the return on investment because we are wasting way too much on unnecessary services that are marginal benefit and not putting it in sort of the fundamental primary care, preventive, chronic care things. So I would put to you, that's something you can do something about right now.
Thank you.
Okay, I think with that...
Can I just make one... all right, just because I didn't... Assemblyman Hernandez asked a question about what could we do different. The fundamental problem, you also have to the incentives are so misaligned, because even in managed care, if I keep that patient out of the hospital under an HMO plan, if it's not Kaiser, that money doesn't come back to the medical group. That goes back to the health plan. So there are fundamental, even in the managed care environment, outside a system like Kaiser or some of the new ACOs, where there's this huge disconnect where the incentives for primary care and the physicians as a whole are completely removed from the money flowing to the hospital. So that's the other thing we have to crack is if we do a much better job in primary care, then there should be a way to recoup that savings back to sort of incentivize that work. Thanks very much for it.
Believe me, I know that frustration. Thank you. Thank you so very much. I'd like to now call up Panel 3, which is the Implementing the Patient-Centered Medical Home Model, Stakeholder Perspectives, Barriers, and Opportunities. We're going to have Sharon Rappaport, Associate Director of the California Policy Cooperation for Supportive Housing, Mark Bloom, Chief Executive Officer, America's Agenda Healthcare Education Fund, Convener, Healthcare Exchange and Advocacy and Responsibility Team, or HEART Alliance, Dr. Michael Katz, Director of the Los Angeles County Department of Health Services, and Dr. Bo Greaves, Medical Director, Vista Family Health Center, Santa Rosa Community Health Centers. And before we begin this panel, I just want to also announce that after this panel, we're going to have our public comment period. So there is a sign-in sheet for a public comment with the sergeants. So please sign up if you wish to comment at the end of the hearing with the sergeants. And with that, I want begin with Sharon Rappaport talking about the Patient-Centered Medical Home and the Affordable Care Act. Thank you so much. Welcome.
Thank you. Thank you for having this really important hearing. The Corporation for Supportive Housing is a nonprofit with a mission of using housing and services solutions to improve the lives of the most vulnerable people. So I'm really going to be getting at the questions that came up earlier in the hearing about chronic homelessness and people who are vulnerable to institutionalization and early mortality. Traditional medical homes work for many with chronic conditions, people like my mother who has COPD, but many do not have the intended impact on people like a gentleman I recently met who also has COPD but was homeless for decades. He was a college athlete who became addicted to drugs after an injury. His health deteriorated on Skid Row, and he dragged an oxygen tank while wandering the streets. His long-term exposure to the sun left his face and head scarred from skin cancer. If he had stayed on the streets, he probably would have died young. Chronically homeless people, on average, die 30 years younger than average life expectancy in the United States. But he was connected to housing and intensive face-to-face case management. He was diagnosed with a mental illness and was able to get treatment. He stopped using drugs, stopped using the emergency departments, and he stopped getting hospitalized because he got healthier. He had been one of the fewer than 4% of Medicaid beneficiaries who drive nearly 50% of Medicaid costs. The majority are people with disabilities with multiple physical, behavioral health, and social services needs. For these individuals, our health system has viewed solutions to improving outcomes and reducing costs with a medical orientation, and so has failed to address all determinants of health, despite what evidence tells us. Evidence shows, for example, one behavioral health condition doubles hospital admission rates. We know providing medical homes to people without a home will not improve their health outcomes and that they will, in fact, increase their number of inpatient days over time. As they can't rest, follow a healthy diet, store medications, or attend appointments regularly. We know, in essence, housing is health care. We know most high-cost beneficiaries are socially isolated and frequently unable to comply with treatment regimens. Managed medical homes often offer one care coordinator for hundreds of patients with little connection to beneficiaries. Coordinators who are located in physicians' offices with little sense of how beneficiaries actually live. Coordination that is provided telephonically with little opportunity to reach beneficiaries who don't have phones, and little responsiveness from beneficiaries who aren't compliant. Multiple studies of Medicare beneficiaries found care coordination models, particularly those offered telephonically, failed to reduce costs or improve outcomes among high-cost and high-need populations. Targeting populations based on medical condition alone means potentially reaching only those who don't experience negative determinants of health or complex health conditions, and leaving those who can't benefit from only a medical approach outside the scope of the medical home. Programs that do significantly reduce costs and reverse beneficiary outcomes target people who are or are likely to become high-cost Medicaid users, then provide health homes to those beneficiaries. And I know you like the term medical homes, Dr. Pan, but health homes basically offer a much more comprehensive approach to people with complex conditions and negative determinants of health. As one example, a New York pilot used a predictive modeling algorithm to identify future high-cost Medicaid beneficiaries. Paraprofessional care coordinators with a caseload, a ratio of 1 to 25, then conducted in-depth interviews of participants to assess need, and then planned for hospital discharge, worked to link patients to housing, provided transportation to and advocacy during appointments, connected beneficiaries to mental health and substance abuse treatment, and expedited appointments. The pilot resulted in almost a 40% reduction in hospital admissions and over $5,000 in reduced Medicaid costs in the first year, above and beyond program and outpatient costs. And the pilot study confirmed many other studies that have been around for quite a while. Dr. Chang alluded to the evaluation of Medi-Cal beneficiaries program participating in frequent user of emergency rooms. That program reduced Medi-Cal hospital costs by $7,500 per beneficiaries per year after 2 years, above and beyond the cost of the program. A Washington study showed homeless chronic inebriates connected to intensive case management incurred almost $2,500 less in Medicaid costs per person per month versus the control group of participants in that study. And 2 randomized Chicago studies of frequent hospital users showed participants decreased hospital inpatient days by 46% after 18 months and nursing home days by over 60% within a year compared to groups receiving usual care. The Affordable Care Act includes several opportunities to fund these types of health home services. The most promising, the health home option, would provide 90% federal funding for 2 years and 50% federal funding thereafter for services like comprehensive care coordination, discharge planning, and connection to housing and other community-based services. Beneficiaries with 2 chronic conditions or a single mental illness are eligible, and philanthropic and county partners are interested in helping the state pay for the costs of the non-federal share. And as Dr. Pan alluded to, the California Endowment has stepped up and offered as much as $30 million a year. The TCE opportunity is really for a broader population than those who are most vulnerable, but it still is a really good, promising step to get health homes implemented in California. The option would provide incentives for managed care organizations to create health homes for high-need populations. And last year, as Assemblymember Mitchell reported, AB 2266 would have authorized the state to take advantage of the health homes option, and she will be reintroducing that bill this year. That bill would also ensure that chronically homeless and frequent hospital users would be targeted populations in that option. The ACA also bolstered existing programs to allow states to fund health home type of services like home and community-based services, waivers required before the ACA, and now the state can do a number of those, offer a number of those services through state plan amendments. They can fund comprehensive care coordination targeted to specific populations that the state identifies, even to people who are not at risk of institutionalization. The ACA also includes funding for programs promising innovations and improved outcomes. California is participating in the 5-year demonstration that was mentioned earlier today for people eligible for both Medicare and Medicaid as part of the Coordinated Care Initiative. The demonstration is a chance to address the whole needs of dual eligible beneficiaries with complex conditions. The ACA offers grants to help hospitals establish community-based multidisciplinary teams linking participants to primary care, and grants from Medicare and Medicaid Innovation, or CMMI, are funding hundreds of programs using care coordination models throughout California. And these grants will inevitably help us understand what works well in care coordination models. Other CMMI grants are creating accountable care organizations, which were mentioned earlier, but there are different models of ACOs, and the Camden, New Jersey ACO is one example that's been highlighted in the past for targeting hotspotters of high costs and poor health, and then using intensive case management to address comprehensively the needs of those health hotspotters. Finally, the ACA includes state demonstrations for pioneering discharge planning models. Given the expansion of Medi-Cal to indigent adults, as well as DMH and ADP reorganization into the Department of Healthcare Services, now is a critical moment for California, in our opinion. We recommend the state consider all options to use Medi-Cal to fund services that comprehensively coordinate the medical, behavioral health, and social services needs of beneficiaries who are vulnerable to institutionalization, to worsening health, to high costs, and to early mortality. We further recommend the state risk adjust or stratify rates to manage care organizations according to beneficiary need and taking into consideration things like homelessness and that risk adjustment. We also urge the state to consider non-medical services and rate setting. Risk-adjusted rates offer appropriate incentives to target and provide care to our most vulnerable Medi-Cal beneficiaries, and other states like Washington and Minnesota have done so successfully. For these approaches to have any meaning, the state must break down silos and, more importantly, mindsets to realize health care is more than medical care, and addressing behavioral and social services needs is crucial to the care of thousands of Californians. Thank you again for asking me to be here today.
Thank you. Now we have Mr. Bloom, who's going to be talking about the role of California Covered California. Mr. Bloom.
Dr. Penn and members of the committee, it's a privilege to be here with you today. Your meeting couldn't be more timely. The role of Covered California is potentially very significant indeed in addressing the staggering burden of health cost inflation, as well as improving health outcomes, particularly for a population which has not enjoyed regularly health insurance coverage. I want to note that today is the 276th birthday of Thomas Paine, who in his book, Agrarian Justice, called on our young nation to create a system of pensions and care for the elderly, the sick, and the aged. How significant it is that today we're carrying on that discussion nearly 3 centuries later. But we're making progress. I'm Mark Bloom, Executive Director of America's Agenda and convener of HEART, the Health Exchange Advocacy and Responsibility Team. We're a statewide alliance of organizations representing millions of Californians in very diverse backgrounds and sectors. We represent businesses, large and small, unions, patient groups, providers, that is, hospital systems, physicians groups, allied health professionals, health plans, and payers. A diverse group of stakeholders indeed, but our HEART members are united around a common commitment to the goals of reducing staggering increases in healthcare costs, improving, optimizing medical outcomes, and driving continuous improvement in the quality of care. We believe that a properly designed, we call it a smart health insurance exchange design, can be an important tool. And in fact, the ACA rules on exchanges offer an unprecedented opportunity to achieve these goals in California. The issue, as we see it, is really the issue of structuring competition in the exchange. There's really no doubt about it. An unstructured healthcare marketplace is not a particularly competitive marketplace for a number of inherent reasons. We see competition in healthcare markets, including the health insurance market, being manifest in continuously rising costs, which you wouldn't expect to see in a more perfectly competitive market, in competition focused not on price and quality, but on competition over risk selection, selecting the healthiest patients. The Affordable Care Act is designed to reduce that risk selection, but the habits and cultures going back a full century of insurance plans are very hard to change, albeit many of them are trying hard to do so. The predominant fee-for-service reimbursement system incents providers to maximize volume of medical services, needed or not, rather than the right care offered at the right time and in the lowest cost setting. There are no villains in this story. There really aren't. They're just economic actors responding to financial incentives in the current healthcare system. And we have health plans passing on rapidly rising medical costs to Californians who pay the premiums. If Covered California, were to opt not to deliberately structure the health insurance market to achieve more optimum outcomes, to rein in cost increases, then we can only expect the same old, the trend to continue to grow at roughly 4 times more rapidly than California workers' wages, to continue to be the largest cost increase in business ledgers, to continue to be an unsustainable burden on the state and local governments. If, on the other hand, the Covered California implements the kind of structured competitive marketplace that we call a smart exchange, there's a significant prospect that California Covered will be the first mover in a virtuous cycle of change, whereby reductions in the cost trend in the exchange can lead to ripple effects in other public programs and ultimately to private programs that could benefit all Californians. Smart structuring of the California exchange is not particularly complex, certainly not as complex as solving problems in our health system generally. The diverse member groups of HEART have identified 3 principles of smart exchange design that, if implemented by the State Exchange Board, would significantly transform this new marketplace that's being created for individual and small business plans into a marketplace that actually could get substantially more optimal outcomes in terms of prices and quality of care. I'd just like very quickly to summarize these 3 principles. The first is that the exchange should emphasize robust competition among health plans. We should encourage all California health plans that meet standards set by the board to participate in the exchange, and we should minimize obstacles to entry by innovative health plans, by new players who are willing to meet the criteria set by the board for qualified health plans. Certainly, without that kind of competition, we can't expect competition to be a positive force in reducing insurance cost increases. Secondly, consumers should have access to transparent, accurate, meaningful, and easily comparable data on medical outcomes and costs. Here I want to emphasize we want consumers to be able to look not just at comparative cost between health plans, but between care delivery options like the medical home and non-medical homes offered by plans. Consumers can only become positive players if they can make rational decisions based on cost and quality of delivery alternatives within health plans. That may, in fact, be the most meaningful comparative choice that they could make in the system. And finally, a smart exchange would require an expeditious and realistic timetable be adopted by every participating health plan insurance carrier to offer all its exchange beneficiaries the option of team-based or medical home care. This would ensure robust competition in the delivery of team-based or medical home care between insurance plans, which doesn't currently exist in California. We believe that team-based care, which includes the primary medical home as a primary practice model, needs to define very clearly and distinctly. We define it as a primary care delivery model that enables a family physician or other qualified provider working in ongoing relationship with a patient and in concert with a multidisciplinary team to coordinate and deliver high-quality health care across all settings: primary care, specialists, community, hospital, and home. I think you'd recognize that this definition could be equally applied to the patient-centered medical home. Indeed, we look at the patient-centered medical home as the gold standard in a spectrum of team-based models that can yield similar outcomes. Finally, I'd like just to point to some evidence that shows that the requirement of health plans to provide team-based or medical home care need not be viewed as an overly onerous financial requirement. To the contrary, studies of team-based delivery of care amongst thousands of diverse practices, including work that Dr. Grumbach, Dr. Grundy have done, show relatively rapid returns on investment from PCMH or team-based care once those practices move into operation. We recognize that a number of different or variants on the PCMH or team-based care model that share common operational or functional attributes can be expected to yield PCMH-like outcomes. I think it's important to recognize this because medical homes will be operating in a variety of different kinds of market environments: regional, rural, and regional urban markets, for example. It would be probably too much to expect one organizational model to flourish and deliver the kind of results we want in all those different environments. I'd like to look at a couple of team-based models that haven't been discussed today, just to point out the kinds of results that they've experienced in very different market environments that are of concern here in California. On the screen here, we've got some results from the Vermont community-based health teams, which were created in the Vermont Blueprint for Health Reform in 2006. The goal of the community health teams is, in fact, to turn rural practices, primarily, small practices, primary care practices in rural settings tend to be, well, kind of cottage industries, often mom-and-pop operations, more than half of them having fewer than 4 physicians, to turn those kinds of practices into patient-centered medical homes in the first place, and secondly, to provide chronically ill patients with the kind of support outside the clinic they need to successfully comply with personal health plans. Well, the results are pretty self-explanatory. You can see after we succeeded in having legislation enacted in 2006, the plan went into implementation in 2009. These are results from 2009-2010. We can see that reduction in visits, inpatient visits to have fallen in hospitals without gatekeeping by 21%, with a 22% reduction in savings. Emergency department visits fell by 32%, with 36% savings in that category. Overall savings to the system was 9%, or excuse me, was 9 and 12% respectively. You note that the savings to the entire system was less than inpatient hospital visits, less than emergency visits, primarily because we saw a substantial increase in primary care visits, fourfold increase over this period of time. That, in fact, is what you want in a successful healthcare system, to manage care at the primary care level much more intensively and without gatekeeping to reduce downstream unnecessary utilization of specialist and hospital services, because patients are getting much more intensive and much more effective upfront primary care. I'd like just to move the slide to the next slide very quickly to the patient-centered, to the direct primary care medical home. This is a system operating in Washington State. It's like the PCMH, except it kind of flips the ratio of the team to the doctor on its head. It reduces patient panels and has physicians working with smaller, not larger patient panels of about 800. The idea being to give the physician more time with each patient. The idea being that the physician can be much more productive in changing patient behavior if he actually knows the patient and has time with the patient. Well, you can see here across the charts the reductions in downstream services, again, without gatekeeping, and in hospitalization, and the resulting estimated savings, this is for 2011, of about 1,727 patients. The real advantage of this model is that it's rapidly scalable, primarily for application in metropolitan areas as opposed to rural areas. And I just want to note that it's been operating in an area where PCMHs are also very active through group health cooperative. So the benchmarks that you see here are ones that include group health. So a really substantial innovation in the potential primary care to deliver the kinds of savings and quality improvements we're looking for. Finally, I'd just like to touch on the response of Covered California and the Exchange Board to this set of recommendations, the kind of smart exchange prescription that our stakeholders have brought forward. I just want to note that it's been warm and encouraging indeed. We've had a series of meetings with senior staff at the Exchange Board, with some members of the Exchange Board. They've been very encouraging. The solicitation to qualified health plans has had lots of questions about the capacity of health plans to offer medical homes or their plans to increase their capacity. We're concerned a bit that there's a failure to define the medical home, a very much overused term in many regards. Many practices define themselves as medical homes where they really aren't by any kind of standard we'd apply to team-based care or to the PCMH. And we think it's important going forward for the Exchange to define exactly what it means and to develop a timetable for, in fact, expecting health plans to develop their capacity to offer every beneficiary in the exchange an opportunity to choose a team-based care model. Indeed, until we do this, we can't expect the kinds of savings and quality improvements that Californians deserve and that, in fact, the system has a capacity to deliver. In closing, I would just like to note that there is a strong patient demand for this kind of care delivery system to emerge, for these kinds of options in the exchange. If we could move to the next slide very quickly. This is one of two polls I'd like to bring to your attention. The first poll, not here, is from the Blue Shield Foundation of California. I'd just like to note their finding that low-income patients want their care to be provided by a doctor, but they're very open-minded to other options, especially a team care model, which may or may not have a physician provider. Among low-income Californians who do not have team-based care now, 81% say they would be willing to try it. Among those who currently have a care team, a nearly unanimous 94% like it. Those are strong findings. You don't find results of patient satisfaction that strong very often, well, certainly not in politics, but not in healthcare either. I'd like to just point out that we did an earlier poll in March. This is findings from that, looking at California voters. 72% which expressed interest in receiving care by a personal physician, a physician-led personal health team that has the attributes of a PCMH or team-based care model. Could we move to the next slide? Because I think that's even more interesting. The next slide shows that the demographics in California that are most interested in PCMH or team-based care are those the identical demographics that are are the targets for state expansion in the exchange, that is, young, non-white, ethnic voters, singles, and the uninsured. Indeed, we may have the most potent response to fears of adverse selection in the exchange here if we offered these kinds of innovative alternative to the fee-for-service fragmented care delivery model, this kind of alternative. Indeed, it looks like there is a strong pent-up demand for uninsured Californians to receive this kind of care. I'll note the comments talking about one of these models, the direct patient-centered medical home of Arnie Milstein of Stanford.
Mr. Bloom, I'm going to ask you to try to wrap up shortly. Sorry.
I'll conclude right now. And who said that this kind of care is not only more satisfying for patients, but it is more satisfying for conscientious primary care physicians as well. Indeed, the California covered, by adopting a smart exchange architecture, stands to provide a benefit in the near future, which could ultimately become beneficial to all Californians. Thank you.
Thank you. I know we asked you to cover a lot of ground in a very short amount of time, but thank you very much for your presentation. Yes, Mr. Chesbrough.
First of all, I want to apologize. I'm chairing another meeting at 4, so I'm going to have to step out. This is a really good hearing, and I want to compliment everybody involved. It's very useful. And you especially, to Mr. Amiano, especially you. That being said, I'm going to do something a little unusual because there's a question I wanted to ask. I want to ask a question in advance of one of the speakers in the hopes that they can address it. And my staff will be monitoring on the tube here what's going on, so hopefully I can get the answer. I just wanted to ask a similar question of Dr. Bishop, what I asked Dr. Greaves, and not to be answered now, but when your presentation comes up. And I realize this is not the primary focus of this hearing, but it's pretty integrated and interconnected. And that is the role that a locally based health plan that involves providers in the governance can play in making sure that there's an adequate network available in underserved communities. To the extent that you have an answer to that, I'd appreciate you providing it. And I, again, thank you for the courtesy of me asking it out of order, and I apologize for having to leave for the other meeting.
Okay, well, thank you, and we'll see that Dr. Greaves has a chance to answer that question as well. So actually, I think the next speaker is Dr. Katz from Los Angeles. So welcome. Thank you.
Good afternoon, Dr. Pan, committee members. Thank you so much for convening this hearing. The experience of Los Angeles County Health Services, which is the second largest safety net system in the United States, our experience over the last 2 years creating medical homes, I think really proves how valuable this hearing is and how much there is to be gained through a medical home model. 2 years ago, Los Angeles care was focused completely on emergency urgent care. You saw who you saw when you went. If it was a Tuesday and you got there at a particular time and there was a particular provider who was next, that was who you saw. We've completely transformed that now to where over 300,000 people are impaneled, meaning they are connected to one particular provider, either a physician, nurse practitioner, or physician assistant, along with their team. And the patient knows that, the provider knows that, and we now work around that model of encouraging people to see the same provider and encouraging the providers to really see their patients and their patient needs as being vital, whether or not the patient is in front of them. You don't necessarily have to have the patient with you. As a primary care doctor, I know that often, as was spoken by Dr. Grumbach, things that can be done by telephone, by mail, everything does not require a visit. Once you switch your model from whoever comes that day is the person you're seeing to I, as a primary care provider, am responsible for a certain number of people. That's my job, to provide them the best health care that I possibly can. Whether they come in or not should depend upon whether I need to physically see them in order to deliver the care that they need. And so we've found that switching to this model has enabled us to drop down our no-show rates. So to give you a sense, of course, people, as you might imagine, are more animated to see their own provider than they are to see somebody that they haven't met. So when someone knows that their doctor, their provider is waiting to see them, they will go to great efforts to come. In fact, because of my regular responsibilities, I only see patients on Thursday afternoons. But people will specifically call me and tell me, and I'll say, well, if you feel like you need to see someone sooner, I'll make arrangements. They're like, no, we know you're there on Thursday. This can wait till Thursday. We want to see you. It's not because I'm better trained than the other doctors. It's because they know me, because there's a relationship, and that is fundamental to the delivery of a medical home, a relationship between a patient and a provider. Does not actually have to be a doctor, which is the brilliance of the team model. I've had some patients who were most connected to the receptionist at the front desk. That was the person they were most linked to, but that was why they kept coming back. So what we've found now that we have switched to this model of giving people an appointment with their own provider rather than the sort of next available who's ever seen, is we've dropped down no-show rates. And this is incredibly important because no-show rates are expensive for a system. So no-show rate means if I've scheduled 12 patients and 4 of them don't show, then I'm just sitting there, right? My nurse is just sitting there. The receptionist is just sitting there. We've missed the opportunity to see people, and meanwhile we're spending money without delivering any positive care. So our experience has been that we've been able to drop down our no-show rate dramatically, which means we can see more people. And so along with that, we've found without increasing staffing, just by going to this empanelment model, we've been able to see more people and more unduplicated clients, more visits, without actually increasing the cost of our care. So that's been one dramatic improvement. Improvements in patient satisfaction with being able to see their provider has been a second. You spoke in your earlier panel about electronic consultations, and so I want to tell you about our experience here. We introduced an electronic consultation system about 6 months ago, and we've so far done 3,000 consultations. Well, Los Angeles, as I've come to learn from being a very big place, numbers multiply very fast. So 6 months, 3,000 consultations. What's notable about that is only 40% of the consultations required an actual face-to-face visit with a specialist. And this is an incredibly practical solution to a problem of cost that has affected urban systems like ours across the country. When I arrived in Los Angeles, one of the things I was told correctly was people are waiting 6, 7, 9 months to see a cardiologist. Okay, if I, as the system administrator, say, okay, well, I want to solve that, I'm just going to hire twice as many cardiologists. Of course, first, a cardiologist earns 3 times what I earn as a primary care doctor. Second, I'm not sure even if we had that money that I would find that many cardiologists prepared to join the public sector system to come work in our clinics. So I'm essentially, if I follow that visit model, I'm consigning my patients forevermore to that kind of waits. Now we've turned it on our head. We have said that in e-consultation, it's not a referral. Referrals could be done by administrators. You don't need doctors to do referrals. If I'm saying is, you should take care of my patient here, send them back when you're done. That's a clerical function. A consultation is I, as a primary care doctor, saying, I'm seeing a person with congestive heart failure. I have them on the following 4 medicines. They are still short of breath. What would you do next? They don't need to see the person. Right, I'm telling them what the specific problem is, but it's gone beyond my ability as a primary care doctor. And I think you've heard in the other ones, works very well, having tremendous success in dermatology, where we're sending pictures. In the case of retinopathy, where we want to set a goal of eliminating blindness due to retinopathy, diabetic retinopathy. It is a preventable disease. And it's the same idea. If your model is that every diabetic in Los Angeles County must see an ophthalmologist, I lose. I can't do it. There are not enough ophthalmologists. We can't afford enough ophthalmologists. If you switch your model to, I'm going to get a photographer to take pictures of people's retina on their primary care visits, and those pictures are going to be sent to the ophthalmologist, turns out that The ophthalmologist looks at the pictures and says, normal, not normal. And even the ones that are not normal save a visit because their visit is to the laser clinic. So if I had actually sent that person with the abnormal retinal exam to the ophthalmologist, he or she would not have been able to do definitive therapy that day because, like many specialties, the procedures are done in a different way. So I eliminate for both people, the person with the normal and the person with the abnormal, I immediately get them to where they need to go. And they're more motivated to keep that appointment. Remember, because think of the message that I'm giving my diabetic. The previous message is it's very important for diabetics to get their eye exam. The new message is we've looked at the photographs and you actually have damage to your eye. It's critically important that you get laser treatment in order to prevent blindness. You're going to get very different show rates for those two messages. So, I'm incredibly optimistic that we can do a lot better in healthcare in California and the United States by really focusing on the role of primary care teams, on how continuity in practice eliminates many unnecessary procedures once someone actually knows the patient and understands the things that motivate them. So I thank you so much for holding this hearing and look forward to working with you on really promoting the medical home throughout California. Thank you.
Thank you very much. And I know you made reference to essentially specialists, but at least in my experience, that includes community resources like getting them into housing and other things where being able to connect that way through the medical home, been able to make that happen. So
absolutely.
Thank you. Dr. Graves, thank you very much for being here.
And as the last speaker, I just want to say, number one, I salute the committee for your dedication to helping us transform primary care, and I'm amazed at your stamina for sitting here and listening to us talk to you for all these hours. So thank you for hanging around. I'm Bo Greaves. I'm a practicing family physician in Sonoma County, and my comments today are going to be a little bit different, I think, than most of the others. It's going to be more to describe some of our experience in collaboration between practices on the ground level. I think we've heard a lot about policy level discussion, things that we need to change about payment reform, manpower supply. This is going to be more how we in Sonoma County, several initiatives we put into place to try and help change the practice of primary care. Because even though we can't flip the switch and say that we're going to go from the current practice in most of our offices to patient-centered medical homes without a whole lot of work going on with how we do our care. So that's the part I've been asked to address today. I've been doing this now for 25 years, and there hasn't been a month that's gone by in those years where I haven't seen patients. I've had several leadership positions in various medical organizations, and currently am a medical director in a large community health center in Santa Rosa. In addition, early on when I started practice, it was obvious that what we were doing needed an overhaul. There was so much inefficiency with how we provided primary care, and you, Dr. Bloom, you described that a lot. That effort to transform primary care, and I wasn't alone in our community, has coalesced in the last decade into this movement across the country to transform primary care into what we now call patient-centered medical homes. I'd like to call out that in California, this movement has had a lot of players and a lot of leaders, but one of the first organizations to lead the charge is an organization I've been involved in for a long time, the California Academy of Family Physicians. For the past 5 years, it's also been my privilege to serve on Sonoma County's Health Action, which is a coalition of leaders from many different walks to come together and figure out how we as a community can address underlying problems to improve the health of the community. So a lot of it doesn't have anything to do with health care. It has to do with the social determinants of health, educational attainment, access to healthy foods and vegetables. But I've also, as the physician on that council have been chair of a primary care work group and chair of their Committee for Healthcare Improvement to really look at healthcare and how we can improve things. One of our earliest projects in Health Action was a PCMH learning collaborative where we brought together 9 different and very diverse practices to collaborate together and learn about patient-centered medical home and learn about change management. We also learned from each other. Each practice developed improvement teams. Some worked on empanelment, which is a key thing. You can't do this without knowing who the population is that you're responsible for. Some worked on access. Some worked on improving efficiency and safety for our patients. All of us met monthly through the year to learn from one another. Several of these practices since that collaborative, and this was in 2008, 2009, have gone on to become recognized as Level 3 patient-centered medical homes by the main accrediting agency, NCQA. Health Action is now, through our Committee for Healthcare Improvement, launching an ambitious community-wide effort to improve care as people approach the end of life. And there are many projects that are part of that. One of them is to improve advanced care planning in primary care by using a team approach and not having it be the primary care physician that has to have that long, very sensitive conversation, and to do it in a way that it is high quality. So a team approach is really a key component of patient-centered medical homes. A third initiative is through the Redwood Community Health Coalition, our network of community health centers for 4 counties. We're engaging in collaborative work to move each health center forward towards this path of transformation with the goal of all of us becoming recognized as PCMH by 2014. This is all being done as part of a large initiative organized by the California Primary Care Association, and they've brought some tools to us, a very powerful web-based project management tool, because to really change all of the different processes of care is a complex thing, and it's very easy to get lost in the rabbit hole of improving one thing, and then you lose progress there and you move to something else. So that has been very helpful. Lots of effort, all this collective work, much of which you've heard from other speakers, is necessary quite simply because the change that we're building is huge. This is not a small thing. And we're doing it while we continue to see all of our patients. So it's like flying an old airplane with propellers and turning it into a 757 jet while you're still flying the plane. Hard to do. Evidence abounds that this is effective. You've heard evidence from Kevin Grumbach and others. There's been a study that was just released last week from the California Primary Care Association comparing cost of care, the total cost of care for health center patients versus non-health center patients in the same community, looking at those high-cost drivers of care. And the results are rather astounding that the health center patients significant reductions in cost, and I'm sure the CPCA can provide the committee with the study. Well, why is that? I believe that it's because community health centers already have some of the elements of PCMH. We have long had a culture of quality improvements in our organizations, and we have team-based care. We have nurses. I never had a nurse in the 18 years as I was out in private practice. So we have people that can do case management and other things. So we're just beginning this project, this journey in primary care. I think we have a long way to go, but I think we've learned a few lessons that I'd like to share with you. One is that we need help to transform. This is not going to happen no matter what they say. Family physician practices, pediatric practices, and general internal medicine practices are not patient-centered medical homes unless they do this transformative work. And they're going to need help managing that. I think the initiatives of the California Academy of Family Physicians and CPCA are a good first step in getting there. Secondly, even before completing this process, partial improvements can lead to significant improvements in quality and patient experience. You don't have to get the full enchilada to actually produce some significant results. Thirdly, I think, and this has been spoken to before and referred to before, not every patient needs the same degree of care and coordination as every other patient. And we need to be much better at prospectively analyzing our patient populations and determining who needs the extra care. And the fourth thing is that becoming patient-centered is requiring new training for all of us to actually be patient-centered. We need to learn to listen, and we need to learn to move the locus of control to the patient rather than around us as coming from a provider-centered care. For this transformation to succeed, and this has been spoken to somewhat before, payment needs to change. We need to move from a payment for visits to a payment for care and for outcomes. And if we can move, we need to move the 40 to 50% of our visits that go to care that we could do in other ways, as you were describing, and replace that with complex care management of those patients that we identify that need additional attention. So I would really urge the committee, the entire legislature, and the Department of Health Services to work with the primary care community and with payers to reform the payment rules, restrictions, and to provide support for this needed transformation, because I think it's going to serve Californians for a long time. Thank you.
Okay, well, thank you so very much. And I just want to open this up briefly for questions for the panel, if there are any. No? Okay. Well, I just want to thank all of you for your presentations. Certainly it has been very enlightening, and I think as we try to move forward and trying to transform our healthcare system and trying to approach not only, of course, healthcare, but also overall the determinants of health and so forth. I think, to try to not only bend the cost curve, but improve the quality of care and also improve health. I, again, appreciate all your insights, so thank you so very much. Thank you. Yeah, actually, Dr. Graves, before you leave, Assemblymember Chesbrough had a question that I think we want to give you the opportunity to answer before we take the public comment. Thank you.
Yeah, as I recall his question, it had to do with, for rather rural, underserved communities that have a difficult time getting a provider, primary care providers.
Correct. I think he was talking about the role of plans, particularly in rural communities, right. County health plans that may have the ability to build the appropriate provider network, physician networks in those communities, and the ability of basically a local plan versus other outside plan or
right.
large plan to be able to do that.
Right. So in our experience, our managed Medi-Cal plan is Partnership Healthcare of California, and while they're not local, they're fairly local, they're regional, and they have been very progressive, and I think that there are things that health plans can do. We feel very represented as they make their decisions. I think that the recruitment and retention of primary care physicians to rural communities is a big issue. And communities, health plans, anybody who's got a stake in the game of providing those services needs to think outside the box and figure out what are the barriers that are preventing family physicians or internists or pediatricians from locating in those areas. And loan repayment's been talked about. That's a huge thing. Housing costs. Overcoming the isolation of rural practice, I think, is an important thing. So I don't have any specific recommendations, but figuring out a way to overcome barriers as they're identified is what would need to be happening. Thank you.
Right, well, thank you. Thank you very much. Thank you, Dr. Greaves. So what I want to do now is open up for public comment. Given the, basically we're going to limit to 1 minute per speaker. If you haven't signed up already on the list, you do need to sign up by the sergeant's desk if you're in line and you have not signed up. So actually what we're going to do is, in terms of the order, we're taking people in the order they signed in. However, there are two speakers who we wish to accommodate to allow them to go first. First is Mr. Jim Barber. Thank you. Welcome.
Good afternoon, Mr. Chairman. Your last speaker admired your stamina. If you wanted to take a break for a few minutes, you wouldn't offend me.
I think we're just going to go and soldier on. So thank you for being here.
Okay. I've got a 5-minute presentation that I'll do in 1 minute on the condition that I'll submit something in writing and ask you to read it. My name is Jim Barber. I have ALS. I'm here with my wife of 45 years and now my full-time caregiver, Cheryl, without whom I literally could not do anything anymore. I'm here today to speak about the multidisciplinary ALS centers and clinics, the established system of care for patients with ALS. Patients with ALS live 2 to 5 years from diagnosis. No cause, treatment, prevention, or cure can strike anyone. The FDA has one approved drug that gives some patients an extra month or 2 of life. Treatment consists solely of symptom management. From a patient's perspective, the medical landscape is ever-changing, sometimes quite rapidly, and it can be overwhelming. How long can I prolong the use of my arms and legs? When will I need a wheelchair? When should I get a stomach tube? How quickly will my breathing deteriorate? How can I communicate when I can't talk? Left to their own devices, patients have to seek individual medical advice at different times, at different places. Very difficult, a daunting and sometimes insurmountable challenge. The answer, in my mind, lies in the multidisciplinary ALS clinics and centers model that promotes a one-stop shop for ALS patients and their families, where they can go to one place at one time, spend 3 or 4 hours, and the experts come to them. Turn the page. Research has shown that attendance at these centers extends life for 10 months, which is more than 3 times what you get out of the one FDA-approved drug. This model is embodied in Section 104.323 of the California Health and Safety Code. We got that passed a couple of years ago. I urge you to take a look at it because it is an effective model for medical homes for patients with ALS and their families. Thank you.
Thank you so very much, Mr. Barber. And we will take your testimony and post the entirety of it on the website. So I realize we are unable to give you the time to present the entire thing, but it will be out there for public review as well. So thank you so very much for being here and taking the time to be here.
Sure.
Our next speaker will be Terry Farmer.
Good afternoon, Chairman Lamb, members of the committee. While Jim said most people with ALS are given 2 to 5 years from diagnosis, Jim's been living with the disease for 7 years. My name's Fred Fisher. I'm the President and CEO of the ALS Association's Golden West chapter. We're here to serve 70% of California's population. And the model that you've been talking about today is exactly the model of care that exists for ALS patients in California. We have 12 such multidisciplinary clinics. They operate within the UC system. They operate within the private for-profit healthcare system. They operate in nonprofit hospitals like Cedars-Sinai. We have clinics at Forbes Norris Center at CPMC in San Francisco. So what we've seen is that this model of care doesn't just help improve the quality of life and extend life. It also creates the opportunity for patients to participate in the search for the cure or an effective treatment to this disease. And having this one-stop shop creates the opportunity to engage the patient community in not just the medical resources they need, 9 different doctors to manage ALS at one time in one place, but also helps them engage in a very robust search for an effective treatment and cure through these healthcare systems. Thank you very much.
Okay. Thank you, Mr. Fisher. So I guess you're with Mr. Barber. So the next person is Terry Farmer, National MS Society.
Mr. Chairman, just a couple more thoughts.
So,
as you're going through your exercise, consider respite care, home care, telemedicine, home care services. They're absolutely crucial to people with this disease who often can't afford or can't get to it.
I apologize. I know you came very far to here, and I do appreciate that we do have to follow the rules. Otherwise, it's not fair to everyone else. So, Mr. Farmer.
Thank you. I'm Terry Farmer.
Thank you. Welcome.
Good to be here. I am chairman of the Sacramento Government Relations Committee of the Northern California chapter of the National Multiple Sclerosis Society, and we're also a member of the California Chronic Care Coalition. As I have MS, and as such, I guess that qualifies me as a chronic disease person. I never regarded myself that way, but I guess that's what I am. And if you define that by the fact that I'm not going to get cured of this, and I'm an intensive user of the medical system, I guess that qualifies me. I have 3 different doctors. The one who deals with my MS is a neurologist. I have a general practitioner because I have bowel and bladder issues. I also see a urologist. I go to these 3 doctors. I get MRIs periodically. If I have the flu, I've got to go to the hospital because I can't move. All by way of saying I use the medical system a lot, and I'm expensive. I take drugs that cost in excess of $1,500 a month. I understand, because I'm in a PPO plan, the importance of coordination and communication among all these providers. So as such, I strongly encourage the work of this committee. We intend to be actively involved in your work, and will provide whatever information we can. And thank you for listening.
Well, thank you. Thank you so very much, Mr. Farmer. Just to give you the order for, I have Mr. Quackenbush from CPCA, followed by Mr. Hicks from CDR, Ms. Bourne from the American Academy of Pediatrics, Mr. Lee from the California Black Health Network, Ms. Dr. Lang from Western Sierra Medical Clinic, followed by Mr. Remack from the Hepatitis C Task Force, I think Sawait. Sorry, I apologize, but I got her name wrong. All right, from UDW, and followed by Mr. Felix from the Mental Health Association of California. So that's who I have on the list so far. Mr. Quackenbush.
Good afternoon, Dr. Pan and members. Thanks for the hearing. We would echo many of the comments that we've heard today from the speakers. So I'll be extremely brief and not to be repetitive. The CPCA is the statewide association of community clinics and health centers. So we have forged a relationship with the National Committee of Quality Assurance, NCQA, to do a health home initiative to help all of our members go through the actual recognition process. We have a very robust initiative, and we are putting a lot of resources and attention to that. Acknowledging that recognition is the first step to transformation, to be active participants in a redesigned local health delivery system transformation process. So we would echo many of the themes today through the coordination and collaboration of all of the providers in the healthcare system to truly provide medical homes for each and every one of our patients. We are part of a CMS Advanced Primary Care Practice Demonstration, 70 sites in California, where once our members become recognized, they will receive a per member per month payment from CMS for being recognized as health homes. And lastly, I do want to draw your attention that we have engaged in a very productive conversation with the Department of Healthcare Services around payment reform pilot projects in which health home model will be central to. And ultimately, the payment reform pilots will have to be legislated and approved by CMS. So we look forward to your support and your involvement in that process. And thanks for having us.
Thank you. Thank you so very much.
Randy Hicks, Californians Disability Rights. I myself have a chronic disease. I have fibromyalgia. My talk is going to be about transportation. It's great to have a medical center patient home, but if you can't get to the home, it's the big issue here in Sacramento County. You know, we had severe RT cuts, and now if I want to go to a psychologist, my psychologist is way on the other side of town, or I have to use paratransit, you have to wait, and the rate has gone up, so you're still paying $5 a ride. So anytime that you're going to have any kind of medical service set up, you want to make sure that they can get to the medical service for transportation, and it's going to be crucial as we get more folks enrolled, especially in the dual integration pilot projects that are going throughout the state of California, that some areas areas don't have any kind of public transportation at all, it's going to be most definite issue that as we go forward, and as we're going to need funding for that. So think about transportation. I can't stress it enough. You've got to be able to get there, whether you're at home or whether you're going to the hospital. Thank you very much.
Thank you. Thanks very much. And I know that in a lot of the discussions, we wanted to underscore that the chronic care model and the medical primary patient-centered medical home talk about community resources like transportation, housing, and so forth. So that is part of the overall model. Thank you. All right, Lydia. Ms. Bourne, thank you.
Thank you. Lydia Bourne, representing the American Academy of Pediatrics. Thanks, first of all, for hosting this important hearing. As you're aware, the concept of the medical home evolved over 40 years ago and was primarily the impetus of the American Academy of Pediatrics. They were looking at providing coordinated care for children, particularly those with special needs. Over the last 40 years or so, there has been an evolution, and we now have not only health plans but employers and other physician groups who are involved in the medical home concept. We know that patients, children, and adults benefit from having consistent, comprehensive care. Also, we know that physicians have better relationships with their patients when they're in such a setting. And we also know that cost and health disparities tend to be lower. We know that having children in care over a period of time as they age, we can see the advent of lower costs because of prevention and early intervention. Finally, we want to be involved in this concept as you move forward. Today, we primarily spoke about adults, but we also understand and want you to understand the importance of having children's issues involved in this issue. So we stand ready to work with you as this issue moves forward. One of the, if you'll allow me, Kelly Hardy had to leave. She's with Children Now, and she sent me a statement. Is it okay to go ahead and read that?
Actually, out of respect of all the people, if you want to come around and sign back in on her behalf,
I'll do
that'd
that.
be appreciated. All right, thank you.
She wanted to stay but had to leave. So
we'll hear it when we come toward the end. All right, Ms. Lee. Thank you.
Thank you. I'm Darcel Lee with California Black Health Network, and I want to thank you, Dr. Pan, and the committee for having this important hearing today. It's an important discussion to the African American community, where chronic disease in every category has reached critical and unacceptable numbers. As this committee knows, California has the fifth largest African American population of any state in the country. Numbering 2 million African Americans make up about 6.3% of California's population, but we also have the burden of the greatest and most significant chronic disease issues in the state. So as the issue of coordinated patient care and access to patient-centered homes, and especially those strategies that activate and engage the patient in proper and appropriate prevention and self-management, continue to take place, we ask that you especially involve California Black Health Network. In our network, we have physicians and we have healthcare professionals who have not only who are not only treating those patients, but have models that we have been proven to be successful. One of our physicians actually is a part of the CMS site, is one of the CMS sites. We also have a model, finally, that is called the Critical Mass Health Conductors program that is very, very successful, and we would like to work with you as a partner to bring forward to you some of the models we see are working and some that we think might work if they were funded properly. Thank you.
Well, thank you. Thank you so very much. Look forward to a partnership. Dr. Lang.
Thank you, Mr. Chairman and the committee, for hearing me. I'm Dr. Frank Lang. I'm a family practice doc and chief medical officer for Western Sierra Medical Clinic, a semi-rural and rural frontier community health care system in Northern California, in Nevada and Sierra counties. You've heard some tremendously great material about the chronic care model, and I just want to expand on just one briefly to draw the committee's attention to the concept of self-management skills. What we're finding as we're transforming our system towards the medical home, the degree to which you can teach patients to feel empowered and know how to manage their own conditions. We're teaching the Stanford's chronic disease self-management course and offering it free, to the degree that the systems and the state can promote and encourage practices to offer those kind of services at no cost to the patients through some sort of subsidy or acknowledgement would be tremendously helpful. Thank you.
Thank you. Thank you so very much. Rimac.
Yes. Dr. Pan, thank you so much for putting on this hearing. I'm Bill Rimac from the chairman of the California Hepatitis C Task Force and member of the California Chronic Care Coalition as well as the Health Exchange Advocacy Responsibility Team. In considering the transformation at community levels for clinics to become patient-centered medical homes, keep in mind a very, very important point, because this is essential for those that have catastrophic chronic illnesses. And that is that remember that above all, let us not negate the role of the patient advocates as a voice as this transformation is occurring. And whatever we are as Californians, our voice when it comes to our wellness must be center stage as we seek the best expectations and dreams for a quality of life we hope to have and pass forward for future generations. Thank you very much.
Thank you. Thank you so very much. All right. And Addie, Ms. Myers, thank you.
Thank you. Again, Addie Myers with UDW AFSCME, Local 3930. We represent approximately 65,000 home care providers throughout the state. We'd like to commend the chair and the committee for encouraging the creation of coordinated care models that can be appropriately utilized as a key tool for chronic disease management. Under the IHSS program, many of you know, approximately 65,000 in-home care workers provide care to approximately 445 aged, blind, disabled individuals who cannot safely remain in their homes without assistance. These services include personal care, domestic and related services, and paramedical services. UDW believes that the IHSS provider can be a substantial and potentially powerful element in a person-centered care coordination model for these individuals with chronic illnesses. IHSS providers provide hands-on, direct care to needed individuals. Despite the critical role that IHSS providers play in caring for these individuals, they are often not afforded the appropriate training. We believe that IHSS providers should have the training necessary to provide these services. Additionally, we believe that any person-centered care coordination model should require individuals' explicit consent to have the IHSS provider participate in the care coordination team. For these reasons, UDW AFSCME urges the committee to promote care coordination models that appropriately and meaningfully integrate the IHSS provider. I have written comments that we can have passed out.
Thank you, and I think we've forgotten them, but thank you so very much for this. Thank you. Mr. Felix.
Rusty Felix, Mental Health America of California. Mental health is mentioned in the staff paper and mentioned occasionally by speakers, but there's a very specific element that needs to be present in medical homes to work, which is two things. One, that people who come to primary care are evaluated for the behavioral health problems, and there is a co-located behavioral health specialist there to start the process of treating them. This is an emerging model, but it's not happening to a very large extent in California. Department of Health Care Services has made a requirement for the Dual Eligibles Care Coordination Project. Kaiser has started to make it universal in the Bay Area. Other health plans on the websites, they say they believe in it, but it still isn't happening. So the question for the legislature, for the health plans, for the exchange, for healthcare services is what will it take to make this a universal thing? All the studies show it pays for itself in improved health and in reduced hospitalization. So what will it take? That's the question. It seems to me we need to work together to get an answer to that. Thank you.
Thank you. Thank you so very much. And sorry, but I appreciate you waiting around and to make the statement. Thank you. Ms. Bourne.
Okay, so this is a statement from Kelly Hardy of Children Now, and if you'll bear with me, I'll read what she sent me. On behalf of Children Now, I thank Dr. Pan for convening this hearing. I want to note that access to well-coordinated health care is particularly crucial for vulnerable children and the long-term well-being of the state, as healthier children make for better students who are more able to lead successful, productive, and healthy lives. Child-centered health plans are already making a difference in California. For example, Children's Hospital in Oakland supports 2 programs that serve youth in foster care and homeless families with children. These programs improve health outcomes by co-locating medical and mental behavioral health services, coordinating needed health care services to maximize coverage and available hospital resources, connecting families with other needed services in the community such as food and transportation, and fostering strong communication among the providers and agencies that serve these families. Outside of California, states like Rhode Island have developed comprehensive programs similar to the one in Oakland. Children Now hopes that the future considerations of medical homes take into account the great promise the model shows in helping to ensure a healthy future for California and its children.
Thank you. Thank you so very much. Seeing that there's no other public comment, first of all, I want to thank again all the speakers who presented today, and a very excellent presentation. Certainly generated a lot of discussion here. I want to thank all of my colleagues who come in and stayed at different parts of the hearing, but I think this is very informative, and also all the people who came up to make public comment. I apologize that given the time we were not able to give people more time, but certainly each of those comments were very important and insightful to us. So, and finally, I just do want to thank my staff, particularly Cassie Royce and Roz Palama, who organized the hearing, and of course, always Patty Rogers, who keeps us all on track. So again, thank you so very much, and this hearing is now adjourned.